A very good morning to one and all present here for our CME program. With the divine holiness and blessings of our Adhiparasakthi Charitable, Medical Educational and Cultural Trust President Arulthira Amma Bangaru Adigalar, under the enlightened guidance of our Vice President, ACMEC Trust, Sakthi Tirumati Amma Lakshmi Bangaru Adigalar, with kind gesture and support of our Managing Trustee, Sakthi Thiru Anbalagan Sir, our energetic and zestful Medical Director, Adhiparasakthi Hospitals, Sakthi Thiru Dr. T. Ramesh Sir. Our heartfelt welcome to our Honorable Dean, Dr. Moman Singh Sir, Vice Principal, Professor Dr. Kannan Sir, our Honorable MS Sir, Dr. Umesh Raj Sir, PG Coordinator Dr. Hemalata Ma'am. We, Department of Ophthalmology, Mappings, take an immense pleasure and feel our deepest respects in welcoming the dignitaries, distinguished speakers, consultants, staff, postgraduates and the undergraduate students to our CME, Diabetic Retinopathy, stay on track. Today we have very eminent speakers who are specialists, well experienced in managing vitreoretinal disorders, who will be sharing their knowledge with us during the subsequent sessions. Dr. Namita Bhuvaneshwari Ma'am, Superintendent and Professor of Ophthalmology, Meenakshi Medical College, Dr. Suresh Sir, Additional Chief Health Director, Head of the Department, Department of Ophthalmology, Southern Railways Headquarters Hospital, Dr. Rajesh Kumar Sir, Vitreoretinal Consultant Associate with MAPIMS, Dr. Kasinathan Sir, Vitreoretinal Consultant. Diabetes mellitus poses a big public health challenge. Its prevalence is increasing due to various lifestyle changes, including our food habits and increased intake of carbohydrates, sedentary nature of our work, increased stress and poor sleep, and also reduced vitamin D levels and lot of etiological reasons which we'll be discussing in this program. Many patients incidentally get informed when they go for some other diseases management. They just incidentally get told that they have diabetes. Many patients feel it difficult to accept the fact that they have been diagnosed as diabetes mellitus, and this way the diagnosis as well as the management, all these things get delayed. As the diagnosis gets delayed, added to the poor compliance to the anti-diabetic treatment, the occurrence of complications such as nephropathy, cerebrovascular accidents, and also especially diabetic retinopathy, these are all on the rise. As we all know, diabetic retinopathy, if not diagnosed at the right time and if it is not treated at the right time, it's a potential cause of blindness. So the purpose of this CME program is for us to get authentic information on early diagnosis and management of diabetic retinopathy. If managed appropriately at the right time, vision is saved. So on behalf of our Department of Ophthalmology, I sincerely wish everyone present here get benefited by the upcoming talks by experienced surgeons and pioneers in this field. By thoroughly understanding the pathophysiology of diabetes mellitus, there is scope to work on the preventive aspects, and diabetic patients would one day love to say, I used to have diabetes long back. Thank you for the opportunity.
Good morning to one and all gathered here this wonderful morning for our CME. We welcome the first speaker of the session, Dr. Namita Ma'am, the Medical Superintendent and Head of the Department of Ophthalmology, Meenakshi Medical College Hospital and Research Institute, Kanchipuram. Ma'am did her MBBS from Madras Medical College and PG from Stanley Medical College and Madras Medical College. Ma'am is the retired Director and Superintendent of RIO GOH Egmore. Being a versatile ophthalmologist, ma'am has also extended her footsteps into the administrative field and has an immense role in hospital management and administration. We welcome you, ma'am, onto this stage to share your vast knowledge on the clinical features of diabetic retinopathy.
With the blessings of Amma, our trustee, I can have this. Thank you. Good morning to everybody. I wish to thank Dr. Venkatesan and his team for allowing me to be part of this CME, and it is a real pleasure to come back to Adhiparasakthi because I've been coming here for 5 years for my son. He did his undergraduation here, and probably some of the faculties are still my son's old teachers. So I'm very, very happy to be part of this program. So today, all of us are very proud that we are Indians for so many reasons. The best scientific programs going on, all that rocket and other science and everything. We can still be proud of us in a negative way that India is the capital of diabetes mellitus. So we all know that because of the lifestyle, food habits, stress level. So we need to change ourselves to how better we can be without the ill effects of diabetes. So diabetes can affect everything, right from skin to the nerves. So today I am here to talk only, I'll restrict my talk only to diabetic retinopathy, which is supposed to be a preventable cause of blindness. And we ophthalmologists know that during our routine checkup, we detect diabetes mellitus in our population who come to us for a regular checkup, even glaucoma. So to start with, I'm going to do the basics of diabetic retinopathy. I think diabetes is important for all specialties. So you need to refer all diabetic patients for screening with the ophthalmologist as a routine, whether they are early detected or late or whatever. The duration really matters a lot. So it's a very important ocular complication of diabetes, and it's more common in type 1 than type 2. And proliferative diabetic retinopathy affects 5 to 10% of the diabetic population, and type 1 in particular has a lot of risk with an incidence of up to 90% after the duration of 30 years. So we need to know the risk factors. The patients diagnosed before the age of 30 years, like maturity onset, 50% of them will definitely get a retinopathy after 10 years, 90% definitely after 30 years of diabetes. And poor metabolic control is even more risky, but it is relevant for the progression of the diabetic retinopathy. Increased HbA1c associated with a very high risk of diabetic retinopathy. What is the relationship between pregnancy? We know that pregnancy-induced hypertension can clear after the delivery, but when it is associated with a pregnancy, it can, in already a pregnant woman, it can progress very fast. So the predicting factors will be poor pre-pregnancy control of diabetes, or too rapid lowering of blood sugar, preeclampsia, where the blood pressure is on the higher side, and fluid imbalance. All these are risk factors in a pregnant diabetic woman. What is the association of hypertension with diabetes is, commonly diabetic patients end up with becoming an hypertensive, or instantly if a patient of mild headache for a long period of time ignored, taken tablets across the counter with paracetamol, suddenly you find the blood pressure is very, very high. By then damage has already been done to kidneys and heart and brain and all. Okay, so we need to have a blood control well below 140 by 80 at any given part of time, and retina is closely related to renal changes also. So when there is a retinopathy in the eye, simultaneously the kidneys also get affected. Okay, that we should be very, very aware of. The other risk factors will be obesity, hyperlipidemia and anemia. High waist hip to hip ratio, the patient has to be screened for diabetes. So what is the basic pathogenesis? Here the main pathogenesis is microangiopathy, which leads to microvascular occlusion and microvascular leakage. This is a picture which shows, I'll show you the better pictures, which shows the viscosity of the blood where the retinal blood vessels get affected, and I'll show you the better pictures. So here when there is a hyperglycemia, you can see that there is here you can see the basement membrane thickening. You see the RBCs become very tough, so they are not able to mold and pass through the blood capillaries, and then you have the platelet adhesives, stickiness of the platelets. That is basic pathology which goes on. Here on the other side there is loss of pericytes. So when this happens, there is occlusion. When there is a loss of pericytes, there is leakage. So lot of leakage of blood and plasma occurs in the around the blood vessels. This is the basic pathology of microangiopathy. Okay, then what happens when there is a basement thickening? There is capillary wall weakening will be there. So there is a plasma leakage, so retinal edema, and you have all these hard X-rays and the succinate pattern of diabetic retinopathy. So when there is a thinning, there is a microaneurysm, then what happens? They burst. There is a pathological change in the vascular wall that leading to intraretinal hemorrhage. So when there is a occlusion, that particular area we'll call it as a retinal ischemia. So what happens? All this vascular endothelial growth factors are formed, which will try to encourage proliferation of the fine capillaries. So we call them as a neovascularization, and there is along with that there is fibrovascular proliferation. So all this can lead to AV shunt in the intraretinal microangiopathy in the retina, and then these blood vessels can go block the proliferative retinopathy and then block the veins. So new vessel formation, they can spread into the periphery of the retina, they can come into the angle of the anterior chamber, and then they can even have involve the entire iris. We call it as a rubeosus iris. So there are a lot of classifications, Minkowski and ETDRS, all lot of classifications are there, but clinically that's more of theory, but clinically we need to know the basic classification as a non-proliferative and proliferative. And in non-proliferative diabetic retinopathy, absolutely normal retina doesn't mean the patient is not going to get a retinopathy. What we see is hardly anything. When we do a FFA or a OCT, we see millions of abnormalities in the retinal vasculature. So we classify non-proliferative into mild, moderate, severe and very severe non-proliferative diabetic retinopathy. In a proliferative, mild, moderate and high risk proliferative diabetic retinopathy. So what are the symptoms the patients complain about? Mostly, unless there is a vitreous hemorrhage or a retinal hemorrhage, the patient is very comfortable, unless there is a macular edema. So macula is the most sensitive part of the retina, where anything happens there in terms of edema, hemorrhage, X-rays, excellent. First, the patient has a defective vision. As long as the macula is not involved, the entire retina is involved also, the patient is very comfortable and moving around. So when there is a diabetic retinopathy, patients are asymptomatic in the early stages, and as it progresses, you can have a mild blurring of vision, vitreous hemorrhages, you can have floaters and flashes. Flashes can be because of increased tension in the vitreous PVD, or a tension on the retina, the stretching of the retina. There can be a distorted vision as a result of that. There can be dark areas in the vision, scotomas, non-seeing areas. You see a bright light, suddenly you can see black spots in the field of vision. There can be poor night vision and impaired color vision. When the macula is involved, cones are more concentrated on the macula, rods are more on the periphery. Dark vision is being perceived by the peripheral retina, whereas bright daylight is perceived mainly by the macula. So there will be an impaired color vision. So there can be a partial or a total. We know people who come with sudden loss of vision because of vitreous hemorrhage. They may not know that they are a diabetic, or they may not know that they have a diabetic retinopathy. So this is how the vision, this is a normal vision, this is a vision with which a patient with the retinopathy can have a blurred vision. Okay, now symptoms are over. Next is the signs of diabetic retinopathy. The basic signs will be, you see fine dots, microaneurysms. You can have hemorrhages, it can be a superficial hemorrhage or a deep dot and blot hemorrhages. You can have hard X-rays are more common than the cotton wool spots. There will be venous bleeding is a very bad sign, and there can be intraretinal microvascular abnormalities, IRMA, and macular edema. Macular edema, the patient comes early. So this picture shows all the ones which are mentioned here. You can see this is the optic nerve head. You can see the upper and the lower branches of the retinal artery and vein. This is the macula. It's about 2 disc. We call it as one disc diameter is 1.5 millimeter. When it is 3 millimeters from the disc, we find that the macula is situated. The center of macula is the fovea, the thinnest part of the retina, through which we see the choriocapillaries, the bright red spot. Okay. So this is a picture which shows new vessel formation, and then hard exudates, and then soft exudates, and cottonwood spots are present, which are soft exudates. So what are these microaneurysms? These are localized saccular outpouching of the capillary wall, which can be seen as red dots. That is focal dilatation of the capillary wall where the pericytes are absent. I told you there are loss of pericytes in the capillaries. Those are the places where there is spouting. So they form as a saccular outpouchings of the capillary wall. Any fusion of 2 arms of the capillary loop will be seen as a aneurysm. So here it can be seen as in relation to the areas of capillary non-perfusion areas, basically on the posterior pole of the temporal to the fovea. So it is the earliest sign of diabetic retinopathy. So this is a picture which shows there is bleeding here. Can you see the bleeding here? And dot and blot hemorrhages are there. So that fundus, when you do a fundus fluorescein angiography, when you inject dye in the antecubital vein, it takes about 8 seconds to be seen in the fundus. So what you did not see there in the regular naked fundus, FFA will show everything. Wherever there is leak, wherever there is microangiopathy, microaneurysm, everything is seen. These are not visible in that fundus. With the FFA will tell you what exactly happening in the blood vasculature. You can see the blood vessel wall and the blood leakage, everything you can see in the fundus fluorescein angiography. So you can see the leakage of plasma constituents into the retina. So these blot and dot hemorrhages are deeper level. You can see within the layers of the retina. This is a part of cross section of the retina. You can see the dot and blot hemorrhages in the deeper layers of the retina, and these are the superficial hemorrhages where you see in the nerve fiber layer. We call it as a flame shaped hemorrhages. So these are the dot and blot and the flame shaped hemorrhages. Both are there. These are flame shaped. These are dot and blot hemorrhages. So I was talking about hard exudates and soft exudates. So these are the ones which we really need to know, because these may not stay for a long time. And so when the blood sugar is controlled, it stays for a short period of time. With treatment it can clear. So these are all accumulation of the intraretinal lipid material. These are yellow colored deposits of lipid and protein within the retina. So accumulation from the fluid leak from the capillaries and microaneurysms. So these can be in a form of a circle, succinate retinopathy, more on the macula. So hyperlipidemia has to be ruled out, or it will be invariably present. You need treat to hyperlipidemia in all these cases. So hard exudates and lipid are directly connected. So this is a picture which shows lot of hard exudates in the macula. This is the optic nerve head. This is the hard exudates, is more concentrated on the macula. Can you see this? Next is the soft exudates. Other name for soft exudate is the cottonwood spots. These are fluffy lesions in the nerve fiber layer, more superficial. These are all infarcts of the blood vessels. So the occlusion of the retinal precapillary arterioles supplying the nerve fibers are occluded, so resulting in concomitant swelling of the local nerve fiber axons. So here the fluorescein angiography will show no capillary perfusion in that particular area of the location of the soft exudates. So this is very common in the diabetic retinopathy, common association of associated hypertension. In a hypertensive retinopathy, soft exudates is much more than hard exudates. So you need to, when you see soft exudates, you have to rule out hypertension. Okay, this is a picture which shows yellowish, white is fluffy, soft exudates in addition to the superficial and deep hemorrhages. So I was talking about the venous beading, which is a dilatation and beading of the retinal vein. So this resembles a sausage. Can you see this black, like a sausage shaped dilatation of the retinal veins? This is a sign of severe non-diabetic, non-proliferative diabetic retinopathy. So this picture shows the IRMA, that is intraretinal microvascular abnormalities. They represent the intraretinal neovascularization, which has not breached the internal limiting membrane of the retina. That's the innermost layer of the retina. So this indicates a rapidly progressing proliferative diabetic retinopathy. So concentrating on the macula, we call it as a diabetic maculopathy. This is because of the macular ischemia, because of the retinal capillary non-perfusion, and it's a progressive non-proliferative diabetic retinopathy. You can have a maculopathy. So this edema can be either focal or diffuse or mixed, both focal and diffuse. So when the macular edema is there, patient definitely has a drastic defective vision. So there will be an increased permeability of the retinal vasculature. So it can be seen in both proliferative and non-proliferative. It definitely causes loss of vision, and it is important to manage macular edema. The others are there to talk about the management of diabetic retinopathy. I am not going into the details of that. So this is a picture which shows, this is an OCT picture. You see a lot of fluid collection here. This is a swollen retina, the entire retina is swollen. Can you see the fluid collection here? This is a normal retina, this is a swollen. You can see the macular edema here, you can see the hemorrhages here. So this is a fundus picture and corresponding OCT here. So this gives a entire layers of the retina, whereas here it only gives a gross picture of the fundus. When you do a FFI, you see much more than what you really see in the fundus picture. So this is the picture which we see succinate retinopathy. This is a macula, paramacular area succinate, focal edema is there. You see the leakage of fluid here correspondingly. This is a fundus picture of a diffuse macular edema, and see the FFA. What you see is so less, and what you see with the FFA is much more, 1,000,000 times more than what you really see in the fundus. So don't take for granted that it's only little changes in the retina. You have to subject the patient to the further investigations to know the extent of the involvement of the retinopathy, so that the treatment will change accordingly. Something called a clinically significant macular edema, that means you have to interfere. Here you see that this is the optic disc. This is the optic disc of the this is the optic disc, this is the macular area, this is the focus fovea. You see a lot of edema, retinal edema. If it is within the 500 microns from the fovea, it is safer and easier to treat. And hard exudates here within the 500 microns of fovea, it's often associated with adjacent retinal thickening. Lot of thickening will be there, and here the retinal edema is more than 1 disc diameter, that is 1.5 millimeters. So any part within the 1 disc diameter area of the center of the fovea, you need to estimate the amount. So depending on that, we have to treat what type of laser to be applied. All that another speaker will talk about that. So this you have to, all of you should know that something, when there is a severe diabetic retinopathy, we call it as a 4:2:1. That is, this is a 4:1 rule we call it. That is, one or more of the following features have to be there to brand the diabetic retinopathy as a 4:1 rule. That is, hemorrhages and microaneurysms in 4 quadrants, venous bleeding in at least 2 quadrants, intraretinal microvascular abnormalities in at least 1 quadrant. If it is there, it is a severe diabetic retinopathy. This 4:1 is a must to remember. At least all the physicians, diabetologists need to know this, so that surgeons, mostly we do not treat diabetes. We send them, push them to a physician or a diabetologist or a cardiologist to take care of the diabetes. Next we will go on to the proliferative diabetic retinopathy. It forms 5% of the total diabetic patients. Here the findings will be new vessel formation. Proliferation is anything new. So it can be neovascularization on the disc or elsewhere. When there is a leak, the entire blood comes into the vitreous, we call it as a vitreous changes and vitreous hemorrhage. See, in advanced diabetic eye disease, this happens when there is an uncontrolled diabetes for a long period of time, and in a patient with diabetic retinopathy, glaucoma is there. That means you have to look for any neovascularization of the angle or the iris, rubeous iridis. So the new vessels in the angle itself can close the angle and reduce or block the drainage of the aqueous outside the eye. So blindness is from the persistent vitreous hemorrhage. Recurrent vitreous hemorrhage can be there. It takes about almost 3 to 6 months for the vitreous hemorrhage to recover, and then along with the vitreous hemorrhage, when there is a vitreous condensation, there will be a traction on the retina, resulting in retinal detachment, and you can have a old opaque membrane formation on the retina. So these are the advanced eye diseases features. See, I was talking about new vessels on the disc. You see this optic disc, you see lot of new vessels on the disc, and the new vessels elsewhere, that is away from the disc. You see lot of new vessels elsewhere, NVE it is called. So same thing with you see the new vessels here. I was talking about the venous occlusion. This is the picture of central retinal vein occlusion. So the entire fundus is like a splash of ketchup. Entire ketchup is splashed on the wall. You see that everything is scattered. Lot of superficial hemorrhages all over the retina. So along with macular edema, the visual defect will be much more than when the retina is not that well involved. So this, you see, this is iris, this is a pupil dilated. You have a nuclear sclerosis of the lens. So these are the new vessels. Normally we have a fine circle of minor here at the pupil area and circles of major at the angle, which we don't normally see. Not visible, they'll be inside the stroma of the iris. But when it becomes more and then proliferates all over the retina, we call it as a rubeosis iridis. So this rubeosis iridis, which was not there in the early period, you relate it to the central retinal venous occlusion. When it happens, it takes about 3 months for it to form a new vessel. Any occlusion will be, the nature is to form a new vessel formation. So new vessel formation will lack media. Okay, so they are easy to bleed. So these grow very fast. They enter the angle of the anterior chamber and encroach onto the iris. So it takes about 3 months. So we call it as a 100th day glaucoma. Neovascular glaucoma is otherwise called 100th day glaucoma. So we have to keep on looking out for intraocular pressure in all diabetic patients. So there are a lot of diagnostic testing. I think another speaker will talk about the testing, etc. But in ophthalmology, fundus fluorescein angiography is a must for all the diabetic patients. It will help you to look for clinically significant macular edema, to know when to interfere, to identify the ischemia of the macula, and intraretinal microvascular presence or absence, abnormalities can be seen, and new vessels, and this you have to differentiate. So you have to evaluate when there is a hazy media. This will help you, but it is not a screening modality. Fundus fluorescein angiography can produce anaphylaxis. Anaphylaxis to the dye, we inject a dye, fluorescein dye, which can produce anaphylaxis, and a patient can die on the table. So we always do a little test in infusion, and then if the patient is comfortable, no cardiac pain, no abdominal pain, then we continue with the FFA. With the advent of OCT, doing FFA, it's become less and less, and it is not a routine investigation. This is another picture which shows different phases of fundus fluorescein angiography. This fundus picture and fundus fluorescein angiograph pictures have to be documented to know whether it is the retinopathy is progressing or responding to your treatment, etc. So you have to know the difference between, if you are thorough with, keep on seeing normal eyes, you will be thorough with variations of normal eye. Now, this can be variant. There are 4 or 5 types of normal disc, and there are 4 or 5 types of vasculature of the retina. If you are thorough with the normal, then you can identify the abnormal retina. So this optical coherence tomography is a qualitative analysis to know the exact location of the pathology, size and shape, what exactly is the abnormal structure where. So this observation will give you a pakka qualitative analysis of the retina, and in the quantitative analysis it tells you the thickness, the 10 layers of retina, each layer has particular thickness. So if there is a thickness variation, OCT is very useful, but FFI is only for a vasculature. So nerve fiber layer thickness is again, all the thickness of different layers can be identified with the help of the OCT. This is a picture which shows normal healthy eye. So this is a normal macula, you see the normal macula, and this is an abnormal macula with a lot of fluid collection and new vessel formation. Ultrasound will tell you when there is a fundus view is not good, or when there is a posterior vitreous detachment or a retinal detachment. It is useful to rule out all this with the help of a B scan, we call it ultrasonography. So traction detachment, traction threatening vitreous retinal detachment, all this can be found. And vitreous hemorrhage, when you are not able to look at the fundus because it is the vitreous media is opaque, with the blood is there in the vitreous, you can't make out the status of the retina, whether it's detached, PVD or etc. So B scan is very useful when the medial opacity, when the corneal opacity is there or membrane is there. So management can be divided into medical observation, control of diabetes, and then laser therapy. Another speaker will be talking about the role of anti-VEGF, anti-vascular endothelial factors when you give intravitreally, that can control the progression of the new vessel formation. So glycemic control is important, the level of activity, health style variation, regular exercises, food intake. Lot of junk food is being very, I mean it's more like a peer pressure, like a friend eats pizza, I also eat pizza, burger. So we don't know what oil, what flour they use, what ingredients are there. More to become an addict, a lot of ingredients, negative ingredients are being added to all that. As doctor, we should be able to tell the people, our own kith and kin, our own children, we should be able to control. Then we talk about others outside the family. So lifestyle has to change for the present world, because we will escape and go. The next generation and other generations are bound to face the brunt of this particular problem of diabetes mellitus. So laser therapy is there to knock off the new vessel formation so that the bleeding is not there. So this is a marks where we do a photocoagulation. This is before photocoagulation, this picture is before photocoagulation, and this is after the laser treatment. The other speaker will talk about the different lasers which are used. This is a focal therapy before and after. See how well this retina has responded. Vision also accordingly gains. So these are intravitreal VEGF agents, Biva and Rani Mazum and etc. There are many. And surgery is, you have, when there is a vitreous hemorrhage, we try to remove the vitreous blood in there and then try to attach the retina, which is with for photocoagulation and retinal detachment surgeries. So this picture is before vitrectomy and this is after vitrectomy. Media clears and the patient sees better. So we need to follow periodically. If the patient is normal, no retinopathy, every year the patient has to undergo ophthalmic evaluation. If there is a mild NPDR, every 1 year, and moderate every 6 months to 1 year, and refer to an ophthalmologist. Severe every 4 months seen by the ophthalmologist, and macular edema you have to see every 2 to 4 months. If the proliferative retinopathy, every 2 to 3 months. So diabetes mellitus is not, we may say, diabetes is there for everybody. It's not like that. We need to live, try to be independent on our own. As long as the vision, mental faculties are fine, we can live independently. Otherwise, we need somebody, either in the form of a stick or somebody with us all the time, aid all the time. So we as a doctor profession, we should not allow the next generation or the generations to come to get more diabetes, incident diabetes. We try our best to reduce the effects of diabetes and try to prevent it. Thanks for the opportunity. Thank you.
Thank you so much, ma'am, for your wonderful speech and for expanding our knowledge. We welcome our next speaker, Dr. Suresh Sir, Additional Chief Health Director and HOD of Department of Ophthalmology, Southern Railway Headquarters Hospital, Chennai. Sir has started his journey in the field of medicine from Madras Medical College and his PG from RIO GOH. He is a leading oculoplasty and vitreoretinal surgeon. We welcome you, sir, kindly to the stage to share your vision on the screening and the investigations of diabetic retinopathy.
Good morning, everyone. At the outset, I would like to thank Venkatesh and team for having me, the Venkatesh duo. And it is a special privilege for me to share the dais with my teacher, Dr. Namita Madam, for all the knowledge she has imparted me and made me what I am today. So my topic is screening and investigation of diabetic retinopathy. See, in life, whatever is interesting is seldom good, and whatever doesn't look good is the one which is going to help you in life. Likewise, screening, as postgraduates, we are least interested in the screening aspect of diabetic retinopathy. We want to know what are the clinical features, we want to know what are the diagnostic modalities, what are the latest in treatment and all those. We just try to mug up the screening schedule so that we pass the exam. But actually it is the screening that is very important in controlling the onset of diabetic retinopathy and finding out cases of diabetic retinopathy. So before we go about screening, I would like to remind everyone as ophthalmologists of our duty. So what is the duty of the ophthalmologist when it comes to diabetic retinopathy is to timely detect sight-threatening diabetic retinopathy, keep appropriate protocols in place for prompt treatment, education of individuals with diabetes regarding their eye status and the risks they carry, and prompt referral to physicians for control of all these risk factors, because diabetes is not only a diabetic retinopathy. As the ophthalmologist, we are more worried about the retinopathy part, but we have to see the patient as a whole. The diabetic control is very important, and it is a coordinated effort of the physician and the ophthalmologist. So this is our main duty. So let's see, what is the problem at hand? We have 77 million diabetics last seen in the survey conducted in 2019, and is expected to reach 101 million by 2030 and 134 million by 2045. So the national survey conducted between 15-19 reported 16.9% of diabetics to have diabetic retinopathy, and out of which 3.6% had sight-threatening disease. That is a very alarming number. So diabetic retinopathy screening, when it comes to India, is mainly opportunistic. When I say opportunistic, there is no policy or protocol in place where everyone who is a diabetic is screened, or in fact there is no protocol in place at all. So whenever a patient, he comes by himself, or we get an opportunity to see the patient, then we screen for diabetic retinopathy. That must not be the case. So we have to see that all diabetics are being screened regularly for diabetic retinopathy. That must be the problem, and that is the problem at hand now. So having said that, we are faced with these four main questions: who to screen, who will screen, where to screen, how to screen, and when to screen. So during the course of my lecture, I will try to answer all these questions as much as possible to my knowledge. So who to screen? Ideally, all known diabetic patients, that will be the ideal condition. Anyone with diabetes have to have their eyes checked. So this would be the ideal condition. And there are certain extended criteria put forward by the intelligentsia, that anyone whose random blood sugar is more than 200 milligram per deciliter, anyone whose HbA1c is greater than 6.5%, any gestational diabetes patient must be screened for diabetes. And we have to establish a comprehensive national diabetic registry. And in spite of all this, opportunistic screening of anyone at risk must be undertaken. So this is the who. Now, having defined who to screen, now who will do this job? Is it the job of the ophthalmologist alone? Is it the job of the physician? Then who this work of screening, who will do that? Again, there is no protocol in place, there are suggestions. If the screening is to be done by the ophthalmologist, that will be the ideal thing to do, because that will be the end of it. We can analyze and we can even go ahead with the treatment, but that is not what is happening. So what are the other things that can be used, or other models that can be used? So there are physician-centered DR screening model. The best thing about this is these physicians are the first point of contact. No diabetic patient or no patient whose blood sugar is high comes to the ophthalmologist first. The physician is the first point of contact, and if we can catch the patient at that point of time, that would be ideal situation. So that is the best thing. So most of the diabetics can be screened at the earliest. But what are the cons? Most of the physicians, they have enough and more to do at their hands, not willing to or not interested in the ophthalmologic training. The cost of ocular imaging, yes, most of the fundus cameras are prohibitive cost. So why should they buy that? They are not going to treat the retinopathy as such. So non-availability of personnel. Suppose I am a physician, I have to invest in buying a camera, then I have to employ a personnel to operate the camera, and I have to constantly collaborate with my ophthalmologist because I cannot go ahead with treating. So these are the downsides of a physician-centered diabetic retinopathy screening model. Now what else can we do? We can ask the optometrist, these and other ocular personnel who are allied to the ocular specialist. So they can be easily trained because they have some basic knowledge about ophthalmic diseases, and they also have easy access to the ophthalmic patients. But again, why would they undergo training as long as they are not going to benefit and the cost of ocular imaging? And the next thing would be a pharmacist based model. Why is a pharmacist coming into this picture? Because in our country, you know, before a patient goes to the doctor, he goes to the pharmacist. He goes to the pharmacy and says, see, I am having fever, give me some medicine. So that is the kind of mentality and attitude the patients have. So the thing put forward was, can't we ask or encourage the pharmacists to be the first, as they are the first point of contact, can they be used to create awareness, and can they be trained to screen for diabetic retinopathy? Last but not the least, why not empower the patient themselves? It is your problem, why don't you get screened? So you screen yourself. So empower the patient. The best thing is it will improve the compliance, but the negative aspect is someone has to teach them what is imaging. The appropriate technology is still not in place, and there are no protocols in place for a patient-based screening model. So there are certain things that have been put forward, like can we use an accredited social health worker like ASHA, or can vision technician or optometrist be trained, or special ophthalmology units be set up? But any of these would be possible only when there is a national initiative. Our thought process cannot much change. We can maybe give our inputs if there is a national survey, but these are all more thoughts and nothing in action as such. Now we have said who to screen. Now where to screen? Now it can either be a hospital based screening, it can happen at a primary health center, it can happen at a district hospital or an epic centers, or a community based screening. What is a community based screening? We have a lot of community outreach programs. There can be mobile vans equipped with a portable fundus camera, and nowadays tele-ophthalmology is picking up in a big way. Then how to screen? Now we have come to a conclusion that okay, these are the people to screen, these are the people who will screen, and how are we going to do this? The easiest and cost effective way is a direct ophthalmoscopy. It can be easily taught. easy to use, low cost, and even non-ophthalmologists can be trained in direct ophthalmoscopy. But a lot of findings can be missed with a direct ophthalmoscopy. But since we are talking about screening and not as a diagnostic procedure, it still cuts eyes. Indirect ophthalmoscopy, it allows for a complete and thorough retinal examination, slightly difficult to master, but routine usage of IDO has to be encouraged, at least among our ophthalmology community. Retinal photographs, again, fundus camera can be used. We have ultra wide field fundus cameras, smartphone based cameras are there. Teleophthalmology has its own set of cameras which are linked to the net, and there are many AI based imaging solutions on offer for these. So since I have been talking about teleophthalmology, I would like to briefly tell you what is teleophthalmology. There are basically two methods of teleophthalmology. One is a synchronous method. A synchronous method is nothing where you have a patient, the patient is on a video call, his eye photograph, maybe his retinal photograph is available. Simultaneously, you can get a consultation from the ophthalmologist in real time, is diagnosed and the appropriate treatment initiated. So everything happens in real time. Asynchronous way is where the ophthalmologist is not available on call. So what you do is photograph his retina, upload the file, the consultant might view it at leisure, then he might put forward his diagnosis. The only problem with the asynchronous method is the diagnosis is delayed and the patient has to wait for the opinion of the doctor. And there are certain basic requirements for a teleophthalmology. You need a fundus camera with a minimum resolution and at least a 6 megapixel camera. And the AO has put forward certain guidance, like at least it must be a single field fundus photography, and there are certain papers which show that a single field fundus photography as a screening tool is good. Okay, but that field has to include both the optic disc and the macula. Okay. Then the big question is to dilate or not to dilate. Here again, if there is a person who has a basic knowledge of ophthalmology, he must be trained to estimate the anterior chamber depth, and if it is not less than grade 2, if it is less than grade 2, he must not be dilated and he must be referred to the ophthalmologist. Otherwise, a dilated fundus photograph can be taken. And these are certain criteria laid forward for the quality of image, because see, teleophthalmology, the ophthalmologist has to completely rely on what is being sent. So it is like just like a computer, garbage in, garbage out. So if you give a very poor quality photo, then an ophthalmologist will not be able to give a proper diagnosis. So there are certain criteria. I will not go into the detail. These are just for your knowledge that there are certain criteria to assess the quality of a retinal image. Again, the personnel who are taking these photographs can be according to the skill based competence can be divided into level 1, level 2 and level 3, and different requirements are there, and a minimum level 1 competency is required for a patient, for a person to grade the images. So we have tried to put forward a quality assurance standard where any DR screening program has to have at least an 80% sensitivity and a 95% specificity, so that it can be considered as a successful program. And any place where this is done, periodic review by an ophthalmologist has to happen, so that the quality standards are maintained. Artificial intelligence. Nowadays, everywhere we see artificial intelligence. Even your washing powder, they say now it is intelligent. They claim that our washing powder is intelligent, only we are losing our intelligence. Our intelligence has become more artificial now. Okay. So what is this artificial intelligence? So artificial intelligence is basically any technique that enables computers to mimic human intelligence. Okay, it is the whole, it encompasses two more subsets, basically machine learning and deep learning. And there are basically three types of artificial intelligence, that is narrow artificial intelligence, the general artificial intelligence and the super artificial intelligence. Super artificial intelligence is basically the machine is going to develop a consciousness and behave almost like a human, like our Terminator. Okay, I will not go into detail of this, just for completion sake I want to know, because most of your papers nowadays, if the PGs go, they will see lot of this artificial intelligence name thrown at their face. So I just wanted them to know what is this. So there are a lot of protocols and people working on artificial intelligence, and the idea is we take fundus photos, we grade the photos as say mild diabetic retinopathy, moderate diabetic retinopathy, and feed it to the computer. Then we train the computer by making it process the image. The computer does not see it as a image of the retina, it sees the image as pixels. So it completely blows out this whole image into pixels, it pixelates the whole image, then it compares its knowledge, whether this is known as monitored training. The computer is constantly monitored and the output is monitored by a person, and we train the computer. Okay, this is how the artificial intelligence software learns. After a certain period, we feed it to a centralized neural networks, and the output now becomes autonomous. Okay, just the basics of artificial intelligence. So where do we stand in artificial intelligence? We already have a US FDA approved AI algorithm in the form of IDXDR. This algorithm is already available in Topcon fundus cameras. It comes as Topcon IDX camera. There are other players like RedMarker, AlexNet, eye grading systems. Even Google is working with a DL system along with Arvind and Shankar Netralia for developing a AI system. So, but what are the basic problems with the AI implementation? There are a lot of variability in the data across platforms. There are different algorithmic biases. There are human barriers to AI adoption, because as humans we are always resistant to anything new. We always want things to flow the same way. So there are a lot of human barriers to AI adoption. There are no quality assurance or no national policy in place. So we have to just wait and watch with our fingers crossed for technology to improve more. So having understood the who, where, what, when to screen. Any naive patient who has never been screened for diabetic retinopathy must be screened as early as possible or at the first opportunity. Previously screened patient and pregnant women I will try to cover in the next slide. So these are established guidelines for screening a known patient of diabetes. If there is no diabetic retinopathy, every year, mild NPDR, every year again, moderate 3 to 6 months, severe immediate, and after that follow up every 3 months, proliferative every 3 months, and no diabetic macular edema every year, no central involving macular edema every 3 months, and central involving macular edema every 1 to 2 months. But having read out this whole protocol, I would strictly advise all treating physicians to take it or customize for your own patients. Okay, it doesn't mean, because there are every patient will behave differently. The basic thing would be to follow this protocol, and if the treating physician feels that any patient requires more frequent follow-ups, please advise your patients to come for frequent follow-ups. It's better to err on the side of caution than to be liberal with them. And diabetic women who are diabetics, it's better to have one retinopathy screening pre-conception. During pregnancy, it's better at the first antenatal visit, and if first visit is normal, at least in the 28th week. These are guidelines given by the NICE, and they also have certain protocol difference within themselves. If diabetic retinopathy diagnosed at first visit, the RCO advises 16 to 12 weeks, and then the AAO advises every 3 months for mild retinopathy and every month for severe retinopathy for a pregnant lady. So what will be the ideal condition? Any person who is diagnosed as a diabetic before the age of 30, better to have one checkup at least by 5 years of onset of diabetes. Greater than 30, better to have it at the time of diagnosis itself. And any pregnant lady, during first trimester, it is a must. So these are ideal conditions. And as I already told, public awareness. It is not only our duty to screen, we also have to create public awareness. It can either be a seminar, lecture, and patient counseling. All goes a long way in creating public awareness. Now I will go to the second topic, investigations in diabetic retinopathy. My professor used to say, don't do investigations just for the sake of doing investigations. Before we embark on any investigating procedure, you must at least have something in mind. I am expecting this, I am expecting to see this. An investigation must augment our treatment or help us enhance our capability. Otherwise, I am having an OCT machine, so I will do OCT for all the patients. I am having a FFA machine, I will do FFA for all the patients. That must not be the mindset. So having said that, let's go. So blood investigations. Why do we do blood investigations? Either to confirm diagnosis that yes, he is a diabetic, because many times a patient comes for a refractive error, because in our setup we do dilated fundus examination even if a patient comes for a refractive error for glasses, and at times we are the first people to say that you are having diabetes, and we are the first people to diagnose diabetic retinopathy. Patient comes to us with diabetic retinopathy not even knowing that he is a diabetic. So to confirm that he is a diabetic, can I have some water? To evaluate diabetic control, to look for comorbidities. It is not that a diabetic patient will only have diabetes. Sorry. They also can have other comorbidities. And last but not the least, for planning procedures. Many a times diabetic retinopathy doesn't end with diagnosis. He might require some intervention in the form of a surgery or an injection. So all these require blood investigations in the form of sugar, blood pressure, lipid profile, renal function tests, hemoglobin. And imaging modalities, fundus photography, FFA, OCT, OCT angiography, and B scan. I will deal one by one. Fundus photography. So these are the basic 7 standard diabetic fundus photography by the ETDRS. There are 7 fields. The first one is centered on the optic nerve, second centered on the macula, 3 temporal to macula, supratemporal, infratemporal, supranasal and infranasal. But in spite of all this, we roughly cover only 70 degrees of the fundus field. But this is more than enough for as a screening tool. So why do we have to do this fundus photography? Because it doesn't add to whatever we have already seen is fundus. So why do this? It helps in documentation of lesion, because once you have seen something really bad happening in the retina, you try to explain to the patient that see you are bleeding from your macula is edematous, you are having a superficial hemorrhage, deep hemorrhage, and after 15 to 20 minutes of talk, he will ask, otherwise nothing to worry, no? That is where this fundus photography helps us. Instead of talking to him for 15 minutes, you just show him his fundus, then it is the vice versa. He will say, it is really bad. No, we were trying to tell him the same thing for 15 minutes. So it is that good. It helps in documentation, helps to explain to the patient about the disease morbidity, and also to monitor subtle changes. See, how much ever we see direct ophthalmoscopy, indirect, we are not going to sit there and count the number of microaneurysms, maybe count the number of hard edge rates, whereas all these are possible if you have a fundus photograph. When you are taking a repetitive photograph, we can say that okay, these microaneurysms have now disappeared, these number of hard edge rates have become more. All these things can be monitored, subtle changes can be monitored if you take a serial fundus photograph. Can be used as a screening tool as it is non-invasive. It is extensively used in teleophthalmology, and these fundus images are the main building blocks for artificial intelligence. So these are some of the, madam has already showed you quite some pictures. This is a neovascularization of the disc, neovascularization elsewhere, vitreous hemorrhage, early hemorrhage from NVE. This is a wide field fundus photo. I will not go into the details of this. Basically, as I told you, in spite of our standard 7-field photo, only 75 degrees are imaged. So this Optos is a new machine which gives you almost 20 degree almost from aura to aura, and it is non-invasive and we can almost see the entire retina. Next, fundus fluorescent angiography. Now what are the indications? As madam told, after the OCT, now the amount of angiography that we do has come down a lot. There are very specific indications for fundus fluorescent angiography. Basically, to rule out macular ischemia, to find out whether your macular edema is focal or diffuse, any unexplained visual loss, any suspected neovascularization or IRMA, any person who is non-responsive to treatment, we want to know what is happening, can guide laser therapy, and FFA can allow visualization even if some grade 2 to grade 3 cataracts, we can still, an asteroid hyalosis, we can still do a good FFA. Asymmetric PDR, to rule out any ocular ischemic syndrome, any associated pathologies, and the main thing would be to find out capillary non-perfusion areas, which can easily be missed with a regular fundus photography. These are some of the outputs of a FFA. You can see leakage, you can see blocked fluorescence. I don't know whether you can appreciate, see this is a deep retinal hemorrhage where you can see the retinal vessel over the blocked choroidal fluorescence, and here it is a superficial hemorrhage that is blocking the retinal vessels. So you can even find out by the kind of fluorescence, we can say whether it is a deep retinal hemorrhage intraretinal or it is superficial to the retina. These are small microaneurysms. These are leakage from NVE and NVD, and here you can see the FAZ has increased, that is the foveal avascular zone has increased, and you can also appreciate the capillary non-perfusion areas. Again, a few more photographs showing these are everything happening in one. And one of the main thing is to rule out ischemic, because these are the people we would have given them all kinds of treatment but of no avail, because we would have failed to diagnose the ischemic part of the thing. So only a FFA can show us that the FAZ has enlarged and multiple non-perfusion areas are there. So what are the limitations? What happens is, it is very difficult, though we talk about finding out the FAZ increase. Once there is leakage, the FAZ becomes fuzzy. Okay, so it becomes difficult to determine the size of the foveal avascular zone. Since it is an invasive investigation, it cannot be used as a routine screening modality. And as madam already mentioned, dye allergy, you can lose patients. So you have to be very careful and not do it as a regular. A few photographs of how an ultra wide field fundus FFA would be. See, these CNPs would have been missed if done with a regular fundus camera, but ultra wide field gives us details about extreme periphery also. A well lasered, still patient is having neovascularization. So having talked about FFA, now we go into the in thing, the optical coherence tomography. This is used extensively for two main reasons. One, it is non-invasive and it gives a hell a lot of information about everything going inside, even in the deeper layers of the retina. So it can not only help us in diagnosis, it can also help us in quantification, monitoring the response to treatment, and also in guiding the treatment, and even gives us details about the vitreomacular interface abnormalities, which can easily be missed, and there are quite a number of OCT biomarkers for us to learn from. And nowadays we no longer talk about clinically significant and non-significant macular edema. OCT has radically changed it into center involving and non-center involving diabetic macular edema. And Kim et al. Have tried to classify DME based on the morphology. This is the cystoid macular edema, the spongiform type, the serous detachment, the taut posterior hyaloid, and the tractional DME. But in more than one types of DME always happens. It is not that the disease studies the book. Many types of DME occur in conjunction. That is known as the mixed type. OCT biomarkers of DME. This is one of the most common questions asked in the postgraduate examination, both in the Viva and theory. So I would encourage all the postgraduates to pay some more attention to the OCT biomarkers. The most common thing which strikes us is the central subfield thickness. The increase or decrease can be used as a correlation to treatment, and it is a very constant biomarker which can easily be measured. And one thing we have to understand is, though we always say that it is directly correlating with improvement, it need not always necessarily have a direct correlation. Why I am saying this is, once a retina is stretched beyond its stretching capacity, there is quite a number of disruptions that happen within the architecture of the retina. So in that condition, for example, if you are baseline, when you are treating a patient, he has around 1000 microns of macular edema, you cannot expect this patient to come back to normal once you start an anti-VEGF or steroids, because his retina has been stretched too much. So there is bound to be a lot of disruption between the connections of the different layers of the retina. So in these conditions, we might the subfield thickness might not directly correlate with the treatment and vision. Next comes drill. Drill is nothing but disorganization of the retinal inner layers. So most we try to see drill within the center 1 millimeter of the retina, but drill happens everywhere and anywhere within the layers of the retina. So what is drill? Drill is loss of boundaries between the layers of the retina. It is basically disorganization between the ganglion cell layer and the IPL. Okay. So what happens, once there is disorganization, it causes disruption between the pathways that transmit the visual information. And as I said, the central 1 millimeter is very important, and anything, if drill is covering more than 50% of this area, it is supposed to correlate with a worse visual acuity. And greater drill at start, that is at baseline, means in spite of any treatment, the outcome is going to be worse. And if the drill is increasing, that means the patient is worsening. And it also suggests disease chronicity. Okay, so drill is one of the main parameters which has direct correlation with visual acuity. Then comes the hyperreflective foci. So what are hyperreflective foci? Hyperreflective foci are supposed to be small dots that are spread across different layers of the retina. They are less than 30 microns. They don't have any acoustic shadowing, and the reflectivity is similar to nerve fiber layer. Why should you know all this? Because there are other dots and dashes that happen within the layers of the retina. You have to differentiate between what those stand for and what are these hyperreflective foci. And why should you know about this? Basically, they are considered to be aggregation of retinal inflammatory cells or lipid extravasations. Some even consider that as degenerated photoreceptor cells. The multiple HRFs reflect loss of tissue integrity and more severe DME. HRF are supposed to respond very nicely to steroids, and any diabetic macular edema which has a high number of HRFs, you would lean towards treating them with steroids than using anti-VEGF as mainstay. Intraretinal cystoid spaces. So intraretinal cystoid spaces are due to leakage and from the blood, increased vascular permeability, and because of the disrupted blood retinal barrier. They can be classified depending on the size as small, which is less than 100 micron, large 100 to 200, and giant greater than 200 microns. Anti-VEGF treatment causes a decrease in the number and the size of cysts. But do they directly mean that the visual acuity will improve? That we cannot say, because as I already told, if the cysts have damaged the different cells of the retina, then we can see an anatomical improvement, but not a physiological or a clinical improvement even with resolution of the intraretinal cystoid spaces. Hyperreflective choroidal foci. They are suggested to occur due to the downward migration of HRF and invariably associated with disruption of the EZ zone, ellipsoid zone. And they are considered as very poor marker, because when I say the EZ zone is disrupted, that means the photoreceptors have also been disrupted, and they are considered as very poor prognostic marker, seen predominantly or more in PDR than in NPDR. Even in this intraretinal cystoid spaces, at times, I don't know whether it is visible there, you can see these bridging retinal processes. These bridging retinal processes tell us that some kind of retinal architecture is still present. Okay. As I initially told, when the retinal layers are disrupted, we are having poor prognosis. So when there is a reference that no, the retinal layers are still preserved, this is associated with good retinal prognosis. So when you show a diabetic macular edema with huge cysts to a patient, the first question the patient will ask is, you are prescribing him Idea, which is say 50,000 rupees, or you are prescribing him anti-VEGFs, which are like thousands of rupees. The basic question is, how will I fare? Will I improve? Will I get my vision back? Why should we know about all these OCT markers? These are the things which will help you give you the reply to that question. So suppose I see a patient with bridging retinal processes, I will give him a positive prognosis. I will say, yes, since the basic architecture of your retina is present, though you have huge cysts, the chances of you recovering with anti-VEGF is good. So that is how all these markers help us. Hard exudates. Already I told you, why should you have definitions for hyperreflective foci? Because this is another hyperreflective spot which is greater than 30 micron, has back shadowing or acoustic shadowing. The reflectivity here is similar to RPE Brooks complex. It is supposed to be associated with the increased lipid levels and responds well to steroids. So you can see these biomarkers even help us in deciding whether to go with a dexamethasone implant or with a anti-VEGF. Taut posterior hyaloid. A taut posterior hyaloid is going to tell you that don't inject. Don't ever try any other modality of treatment, because nothing is going to help. These people are those people who need surgical management. Photoreceptor outer segments. So basically what is a photoreceptor outer segment is the length between the inner and outer segments and the RPE. So I don't know whether it is visible. See, this layer is the photoreceptor outer segment, and see, as long as it is normal, it is associated with good prognosis, and if there is a decrease in the photoreceptor outer segment length, it is associated with poor prognosis. And loss of parallelism is where the parallelism between the different layers of the retina is lost. It is similar to drill but happens within other layers of the retina. Subfoveal neurosensory detachment. Actually, it has been shown that any patient with baseline diabetic retinopathy or diabetic macular edema, if he has a subfoveal neurosensory detachment, it is associated with good visual prognosis. But how to treat? There is a lot of confusion. The Vivid and Vista study shows that they do very good with injection Eylea, whereas Moon et al. And Zun et al. They have shown that they do well with DEX implants. Just for conclusion, to cover the other modality, biomarkers, we have the subfoveal choroidal thickness. A greater baseline choroidal thickness is associated with better functional and anatomical outcome, because if the choroidal thickness is good, it shows that the choriocapillaries are intact, and so there is lesser outer retinal ischemia. And next, the ELM and EZ integrity, if they are disrupted, it always leads to suboptimal vision recovery. Choroidal vascular index, it is basically a ratio of the choroidal luminal area to the total choroidal area. If it is not altered with choroidal thickness, and PDR patients are supposed to show a very low CVA, and they do bad with treatment. The latest in one of the diagnostic modalities is OCTA. I will not go into the depths of OCTA. Basically, it is a non-invasive technique helping us in imaging the various layers of the retina. The amount of area that can be imaged with the OCTA as of now is less, though wide field OCTA is still available, but not very much available. So what are the limitations of OCTA? There is lack of information on peripheral retina. It cannot delineate all microaneurysms, so FFA is required. Leakage, since I told you we are not injecting any dye, leakage cannot be made out, and since it depends on the movement of RBCs, slow flow can easily be missed, and motion artifacts are very common. There are various algorithms in place. We'll just skip over this. These are some basic slabs of OCTAs. So just to show how some of the abnormalities, this is how a microaneurysm looks in a OCTA. This is how a enlarged FAZ is seen. So some of the OCTA biomarkers is FAZ enlargement, deep capillary plex loss, and poor vessel density, everything pointing to a poor visual prognosis. Then we have the fundus autofluorescence. Again, I will not go into, I am just trying to tell you that all these things are there. There are various grading of 1, 2, 3, 4 depending on the amount of autofluorescence, and increased autofluorescence directly shows, that is any patient showing a grade 3 to grade 4 means poor visual prognosis. Last but not the least, B scan, mostly done when the media is opaque, either a dense cataract, vitreous hemorrhage, retinal detachment in a dense cataract, and it helps in finding out vitreoretinal traction, RD, and vitreous hemorrhage. Others, microperimetry, multifocal ERG, seldom done, just for theoretical purpose. If you are writing your theory, you can briefly mention about them. The future, what does the future have in the form of imaging? There are near infrared reflectance imaging, FLIO or fluorescence lifetime ophthalmoscopy, adaptive optics. Adaptive optics almost allows you to image each and every cell in the retina. You have multispectral and hyperspectral imaging and multicolor imaging. Thank you.
Thank you, sir, for enlightening us about the screening and investigation of diabetic retinopathy, and your update on recent advances on the teleophthalmology and artificial intelligence will not only be useful for the postgraduates but also to our consultants. Now we will continue the brainstorming sessions after a tea break of 15 minutes. I request you all to kindly assemble here at 11:30. We welcome our next speaker, Dr. Rajesh Kumar Sir, who procured his MBBS from Sri Ramachandra Medical College and MS from Meenakshi Medical College, Kanchipuram, and is currently working as a vitreoretinal consultant. We welcome you, sir, kindly to the stage to enlighten us on diabetic retinopathy, right path to combat.
Very good morning to one and all present here. At the outset, I would like to thank Dr. Venkatesh and the Melmaruthur team for giving me an opportunity to talk about this topic. So, the two speakers before me spoke about all the clinical features, the investigations, and mainly Sir spoke a lot about screening. I think as the topic suggests, right path to combat, first it starts with screening rather than your clinical features or your treatment. The most important is screening. So I'm just going to divide my talk into 3-4 parts. First, as what should a patient do? Next, what should a doctor do? Third, what do I have in my arsenal? And fourth is just what to go back home with after listening to my boring talk. Sorry, you'll have to bear with me for another 15-20 minutes, I guess. So this is how I'm going to divide my talk on. So first, as a patient, the first right path to combat starts from the patient. Everything starts from the patient. All the complications with diabetes causes can be prevented most of the times. So it is a chronic disease, as we know, which needs very long-term or maybe treatment for life. But I think there are a lot of studies and either which shows diabetes can be reversed. So every 3 to 6 monthly followed by a physician and every yearly checkup by an eye doctor is a must. The main point is the last one, strict diabetic control. It's just not diabetes, it's all the other factors also, like your hemoglobin levels, like your renal parameters, your blood pressure, which everything has to be under control to keep everything under, to prevent complications. So as a patient, what difficulties do they face? There are a lot of comorbidities which happen along with the disease, mainly your renal factors. Because nowadays I think everybody has a very active lifestyle. So when you're 40 and you get diagnosed with diabetes, so like madam was saying, your pizza junk, your burger junk goes, which is one of your main parts of your life as a youngster. You want to eat outside, you want to go out with friends, everything. And next is a financial problem. Nowadays everything has become so expensive. Your housing, everything basically. Your treatment for diabetic retinopathy is not very cheap. It is very expensive. And it is not very fulfilling also as a patient. You can explain the patient, yes, all these factors are there. You can tell the patient, okay, you can expect so much, but the patient is not very happy. Except if a patient only has one eye and he sees he gets some good vision, okay, maybe it is. And like I told you, everybody has a very active lifestyle. If they develop, say, a chronic kidney disease which needs dialysis maybe every alternate day or every 3 days, you have to see a patient with the chronic kidney disease just going to a doctor. He is very debilitated. It has a lot of mental effect on the patient as well. He takes a lot of stress, everything, because it's a very fast-paced world nowadays. So again, what I'm trying to tell you is again, screening is very important. Please, as a doctor, as anybody, as an optician, as any paramedical staff, everybody has to advise patients to get a regular screening. And there are very frequent consultations with the doctors, which is also very time-consuming. So again, she has already spoken about screening. I'm not going to go into the details. Okay, next is the multi-speciality approach. Just a physician or an ophthalmologist is never going to treat a diabetic patient. It needs main consultation by a first, like Sir said, the first person a patient goes to for a general checkup is a general physician. A general physician has to make sure that he sends the patients he encourages the patient to go for a ophthalm consult yearly. And in a multi-speciality hospital like Melmaruthur, it is very easy to get consultations from all the specialists on the same day. If you work in a very dedicated eye specialty hospital, it becomes even more difficult for the patient because he has to come to your clinic or your hospital once, he has to go to the physician the next day, he has to go to the nephrologist the third day, so this is 3 days over. But in a college like Melmaruthur, maybe you can get all the consults on the same day, which is little easier for the patient. And this is what I was talking about. So this is what we are supposed to do when a patient comes to us. So what do I have in my arsenal? In my arsenal, So obviously my clinical diagnosis and skill, which I've procured over time, fundus fluorescent angiography, the OCT, the B-scan and my laser machine. What do I have in my operation theatre? The intravitreal agents which we commonly use, anti-VEGF agents, like already sir spoke about. We have another name for anti-VEGF agents. Now it's, I and at least my colleagues who used to study in do retina fellowship in Coimbatore used to call it Ganga Jal. Any retinal problem, you just put anti-VEGF and you hope it becomes okay. It is not like that. Okay, and next stage in treating is like you have customized LASIK. So next, lot of studies are going on customized treatment for diabetic retinopathy, which I'll be talking on the future slides. These small gauge vitrectomy systems are a very big boon to a vitreoretinal surgeon. The wide field viewing systems, advanced microscopes. You have the new Ingenuity system where you don't even have to, which are basically 3D viewing system, which I'll be talking about. So first, I'll just talk about the, most of my talk is going to overlap with the other speakers. So I'll just try to keep it as short as possible and give you some new input other than what they already spoken about. So basically, like sir said, these are the indications when you have asymmetric PDR, proliferation on one eye, the other eye, no proliferative changes seen clinically, unexplained vision loss, to differentiate between neovascularization and IRMA, and treating CSME, and to see the extent of capillary non-perfusion. So these are the new age machines which give you a very wide field. Like sir told you, he spoke about 7 images, but still it gave you only a 70-degree view of the fundus. A lot of new studies are showing, we always think about diabetic retinopathy as a more posterior disease. So if you see the posterior pole, it should be enough. But a lot of studies are showing something called silent diabetic retinopathy, where the posterior pole is very, you don't see much features, but there are a lot of features in the periphery. So only these machines can actually pick up those diseases. But only problem is all these machines are way too expensive. You cannot have it in your clinic, unless you have a very big setup, you cannot own these machines. That is the only drawback. And you have, I don't know, there are so many new machines which have come out. This is just a photo showing the wide field, ultra wide field angiography. It ranges anywhere between 120 degrees to 200 degrees. But like I told you again, these are very, very expensive machines. So probably if you don't have access to it, you can always refer to the patient where the machines are available, and you can. So you can see here, this area is all non-capillary dropout. There is all the areas of non-perfusion. This is your leakage, which shows basically proliferative changes. So what can be picked on FFA? Basically you look for two things, the type of maculopathy and the grade of diabetic retinopathy. Like already madam told you, what you see clinically and what you see on fundus fluorescent angiography, there is a million changes which you can see on a fundus fluorescent angiography. But there are some drawbacks to the angiography, like obviously anaphylaxis and other reactions. So the three main types of maculopathy are focal, diffuse and ischemic. So these are this is a focal maculopathy. These are areas of focal leakage from specific capillary lesions. If they are not very center involving, you can always treat them with a simple focal laser. So these are the images showing. Diffuse is extensive areas of capillary abnormality. This is a long standing. Basically on FFA you see some late leakage with pooling. So you can see this is the first image. This is the fundus angiogram, the fundus photo. These are the early image of the either. You can only see focal leakages, and this is the late stage where you can see a lot of leakage. Ischemic, again to rule out, to look for unexplained visual loss. Basically, like sir already told, here the foveal avascular zone is enlarged and it is distorted. And going on to the OCT, what you can pick up on OCT is qualitative and quantitative. Qualitative is your cysta macular edema, subretinal fluid, hard exudates, hyperreflective dot. All these has already been spoken about by sir, so I will just skip through. These are the classification of diabetic macular edema based on your OCT. You have your spongy or diffuse thickening, you have your cystoid spaces, these are the cystoid spaces. Sir already spoke about the size of the spaces also. You have your serous retinal detachment and your vitreomacular traction. So again, just another word on the OCT biomarkers. Your central subfoveal thickness, subfoveal detachment, the drill, which is the disorganization of retinal inner layers, external membrane, limiting membrane disruption, the ellipsoid zone disruption, and the hyperreflective foci. So I'll just skip all these because this has already been spoken to. So basically, in which condition, where you can tell your patients, okay, you might get good vision is the presence of SRF is a good indicator. The intact ellipsoid zone and interlenticular membrane, absence of hyperreflective foci, and attached vitreoretinal interface. So, sir already spoke to about OCT angiogram. I'm not going to go into details. The only drawback of the OCT angiogram is the field of view is very, very small. So obviously the peripheral lesions you're not going to go pick up. Maybe another 10 years down the line we might get very wide field OCT angiograms with a lot of side effects, with side drawbacks being there. This is just the photo showing. Going on to the B-scan ultrasound, when do you do it? So basically it's just not for diabetic retinopathy. Even if your patient has a corneal opacity which needs a corneal transplant, you can always do a B-scan just to see if your retina is okay or not. Because if there is a retinal detachment, there is no point in wasting a tissue, because there is very scarcity of tissue in India, corneal tissue I'm saying, corneal buttons at least. If there are cataracts, you can always do a B-scan. I'm talking about like advanced NS4, 5 mature cataracts. So this is just a photo showing retinal detachment. Here, the patient has to be taken up for surgery. There is no other indication because the whole macula is just lifted up. This is just a photo showing a vitreous hemorrhage. If it's a very fresh vitreous hemorrhage, you can still wait for 3 to 4 weeks for the vitreous hemorrhage to resolve. If it doesn't resolve, then you can probably plan for a vitrectomy. So coming on to the next, which is green laser. These are indications which I put across, which I use my laser for. This is not based on any study or anything. So you have your pan-retinal photocoagulation, which is done for the proliferative changes. You have your focal photocoagulation for leaking aneurysms. You have your grid laser for diffuse maculopathy. This is how you do a focal laser. All these yellow are the hard exudates with the central area of thickening, and the red spots are the focal laser which you are given. But make sure that all these are at least 500 microns away from the center of your fovea, from macula. So this is just a photo showing all the focal laser which we have given. Here the spot size which we use is 50 microns. The intensity of burns is, there is no specific, you can titrate according to the grade of burns you need. Basically you have to see the blanching of the microaneurysms. This is another photo showing a focal laser done across the succinate retinopathy. This is the OCT image showing for the macular thickening before and after laser. You can see all the red area, which is the edematous area, which is completely resolved. This is a photo showing a nice resolution of the succinate retinopathy 7 months following laser treatment. So grid laser is basically you're doing you're giving spots like around 100 microns, one spot with each other to area of retinal thickening. You're not aiming at the microaneurysms like in focal. You're just trying to, this is the mechanism. Basically you're trying to activate the RP so that it absorbs the fluid. Laser removes the unhealthy RP cells, which is then replaced by more viable RP cells. It destroys the retinal photoreceptors and decreases oxygen consumption, which in turn decreases blood flow. It basically here, this is the main point. It stimulates the existing RPE to absorb more fluid. This is the basic mechanism of action of your grid laser. Obviously, everything is not, everything has a complication. So, and these are permanent complications where nothing can be done. If you're doing a grid laser, you have to be very careful, make sure the patient is very stable and looking straight. If he moves even a little, you're going to burn the fovea. So obviously it's going to cause a permanent central scotoma, permanent visual loss. There is nothing you can do also. There are paracentral foveal visual loss and scotomas. Always remember these photo burns, the laser burns which you're giving are going to enlarge as days goes. So you can always, the photocoagulation, that's why I always do it little away from the macula. I don't do it very close. There are a lot of daring surgeons who do it very close to the fovea. I'm a little, I'm not that daring for now at least. This always can be subretinal fibrosis. If you give a little too intense burn, it can obviously cause a iatrogenic choroidal neovascularization. Treatment completely changes, which has to be treated with anti-VEGF. And this coming on to the PRP, which we do for proliferative changes, all the proliferative. So this is just a pattern we completely do from the ora to ora, as close as possible to the arcade, just leaving the center of your retina. So you've done under topical anesthesia, usually 1 to 4 sessions, usually 2, always inferior of first half of the retina, because if the patient always develops vitreous hemorrhage in between, it will always go settle down. So superior retina might be visible, where you can give more laser. So always go for the inferior half of the retina first. This is just a photo showing your PRP scars. Another PRP technique is, again, obviously it has to be one burn width apart. Again, here the size only is the same. The power, the duration, intensity, it depends on your grading when you do the burns, when you do the laser. Here you always have to remember, you have to avoid the large blood vessels, hemorrhages and fibrous proliferative membranes. This is a new laser called Pascal laser, which is a pattern scatter laser. This basically, the advantage of this is there are already, this is not completely, this laser is done by manually, and if you can see all these burns which are evenly spread out, this is the pattern laser. This is just a photo to show you the difference. This already has, the machine already has some pre-built patterns in it. So all you have to do is basically 1 foot pedal gives you from anywhere between 9 burns to 25 burns per visit. So the entire PRP session takes around maybe 3 to 4 minutes rather than your regular single delivery patterns. That's the only advantage of this. You can always do a focal laser to your neovascularization for its regression. So okay, you've done the PRP, so next what? You call the patients 2 months later and then you decide what has to be done. So you have your first part is the poor illusion, where the neovascular membranes, the new vessels have not regressed, there is still persistent vitreous hemorrhage, and you have your patient who has a good response to your, where you will see regression of the neovascularization, residual ghost vessels or fibrous tissues. Obviously in the first, where you not had the complete effect, you need to retreat the patient. Retreatment, what are the indications? Again, progression of new vessels, no regression of new vessels, a recurrent vitreous hemorrhage. So you will be thinking, sir, I've already given laser, where do I laser more? So you can always give burns in between. I told you, okay, you have to leave one more burn width apart, but you can still give it in between. And if you not lasered very peripherally or very posteriorly, you can always fill those areas. Again, these also have complications. So worsening of diabetic macular edema has been noted. Reduced contrast and color, obviously restricted visual field, restricted night vision, choroidal detachments and exudative RD, pre-retinal membranes, and again accidental foveal photocoagulation. So, okay, coming on to the next, which is what I have in arsenal is something called intravitreal agents. So basically 2 types of agents we have. One is the anti-VEGF, another thing is the steroids. These are the most commonly used anti-VEGFs. There are a lot more which are coming into the market, but in my experience, most of the medicines have the same effect. Some studies, depending on what study there's a difference, but most of the anti-VEGF agents have the same response in my clinical experience at least. So next is the intravitreal agents, which is the Ozurdex implant, dexamethasone implant and the triamcinolone. What are the advantages of the intravitreal injections? Basically, it can overcome the blood-ocular barrier. It's a closed cavity, so prolonged action of the drugs, maximum therapeutic effect locally without minimal systemic toxicity. Okay. Now, this is where I think the next studies are going to go into. Like I told you, customization of your treatment. So, intravitreal, which one to choose? Like sir was already talking about those hyperreflective foci which are less than those 30 microns. Serous detachments respond better to steroids. You have your spongiform thickening which responds better to anti-VEGF, but still we do not have enough data to quantify. Like I told you, maybe 5 years, 10 years down the line, when we have long-term studies, we will be able to come to a conclusion as to which will respond to what and customize the treatment as per the patient. So these are the 2 stages which you always look for, vasogenic and the inflammatory DME. So what are the indications of the anti-VEGF? Central involving DME, obviously, rubeosis iridis, which madam already spoke about, NVE or NVD, which is neovascularization of disc or elsewhere. I always give it when there are no fibrovascular membranes, because in my experience, whenever I have given with fibrovascular membranes, it has caused more traction and it's called a complete TRD. Or if you're going to take up the patient for surgery within 1 week or something, you can always inject them with the anti-VEGF agents, because their bleeding will be less during a surgery. So the current indications for steroids are, these are always a second line drug for patients with center involving DME who are non-responsive to 3 doses at least of anti-VEGF. More appropriate in pseudophakic eyes or patients undergoing cataract surgery. Pregnancy, obviously you cannot give anti-VEGF. Patients with recent cardiovascular event or cerebrovascular event. In post-vitrectomized eye, only Ozurdex implant will work, nothing else is going to work. And in patients for whom monthly follow-up is a challenge. So, fine. So next, let's just talk about which anti-VEGF is best. Like I told you, depending on which study you read, the answer might vary. It's all up to your decision which you have to choose and through your experience. So there are a lot of studies by something called DRCR-net. So there are some protocols from A to Z there are. So I'm just talking about protocol T, which compared aflibercept, which is Eylea, to ranibizumab over 2 years. If you can see the results, with patients from 2032 to 2040, there is maybe 1 letter difference in the improvement, and 2050 or worse, there was a 5 letter difference in the improvement, which is not a very big, which is not significantly statistically significant. Like I told you, you can give any anti-VEGF for the only thing is the central foveal thickness reduced more in the aflibercept group compared to the bevacizumab group. So going about management of diabetic macular edema, FFA, like madam said, it is not needed for everybody. Like sir said, do only if it is indicated. Okay, so you do FFA, you find it exudative, and you can quantify it into exudative or ischemic. If it's exudative, to see if it's focal maculopathy or diffuse maculopathy. If it's, then you do an OCT. If your microaneurysms and everything are 500 microns away from the fovea, just treated with laser, because these patients will have pretty good vision. If it's within 500 microns, you can always do laser and give intravitreal injections. If it's spongiform thickening, you can just do laser. If it's testoid macular edema, you can always give intravitreal injections. Macular edema with traction is always, vitrectomy is only indicated. Macular edema with neurosensory detachment, anti-VEGF injections or whatever. If it's ischemic, if it's edema, it's the same as exudative. If there's no edema, you can evaluate for nephropathy. So going on to pointers for for DME management, anti-VEGF injections plus or minus macular laser is the most effective treatment. They always, anti-VEGF agents improve vision over laser and steroids. They are always definitely better than steroids. Steroids, like sir told, it might give you a very good anatomical result, but the physiological and visual results might not correspond. And this last point I just wanted to say, patient eyes with good vision with DME can be observed. Good vision in the sense 6-9 vision is, and there is a lot of DME, you can just observe the patient, and you can always go for a rescue treatment if the patient is, if the vision drops or if the edema increases. So just to summarize, anti-VEGF is always the first line treatment, with additional deferred laser is the first line. Patients vision with 20/50 or less, aflibercept or ranibizumab are better. Basically, these studies are all done in the US, where they give very frequent injections, which is not possible in an Indian crowd. So here, the DRCR-net, the rescue treatment or the first primary treatment is they give 6 monthly injections to attain stability, and then as and when needed. So which is not possible in our, you have to tell patients, I'll give you 6, then we'll see the response, then we'll change your treatment. You'll be like, enna doctor, enna solringa, you gone mad or something? He'll go to another doctor. That's a simple thing. And another doctor will tell him, he'll go to the third doctor. It's the same routine which goes on here. So it is very difficult to convince the patient, where patient counseling is very, very important. Like I told you, patients vision better than 20/25, you can just observe. This is what I was telling about the DRCN regimen. The loading dose, they give 6, 1 treatment with anti-VEGF injection, retreat every 4 weeks up to 6 months. So basically 6 injections you are giving. So once the stability is reached, you defer injections if edema or vision stable compared to the previous 2 injections. Increase follow up to 16 weeks stable. PRN, as and when need, you can inject. If edema returns, focal laser if required. Obviously, again, this also has complications. So these are the complications of the intravitreal injection. Endophthalmitis, which is the most dreaded complication we come across. vitreous hemorrhage, raised intraocular pressure, which are more common with the with the steroids, intravitreal steroids. Retinal vascular occlusions have also been reported: corneal abrasion, cataract progression, retinal detachment, intraocular inflammation, retinal pigment epithelium tear. In summary, what to do and what not to do when you're giving intravitreal. Pre-op counseling is the most important thing. Aseptic precautions, you can always ask the patient to come back if there is any redness, drop in vision. Don't is, you cannot give anti-VEGF in a pregnant lady, recent MI or a recent cerebrovascular stroke. Don't give steroid in a steroid responder or patients with advanced glaucomas, and don't inject with periocular infections. So going on, these were about my intravitreal injections. Going on to the next, small gauge vitrectomy. I've always grown up and I've learnt my vitrectomy through small gauge instruments only. I think maybe Dr. Suresh might be able to help us with the old gauge machines, because they used to make very big sclerotomies, which there was a lot of wound leak. You had to put stay sutures and it was very difficult, and the cut rate was very low. I'm pretty sure they felt there's a lot of difficulties. There was no something called PFCL, no dyes, nothing. But there is a lot of advances in the technology. So 23, 25 and 27 gauge are the readily available size of the instruments which you can get. So basically, what are the advantages? Most of the surgeries are done and which is sutureless. There is less post-op pain, or as a sclerotomy heal up very fast. There is less glow fluctuation during the surgery, because every time you have to remove your instrument and go back in, if it's a membrane peeling case, when you remove, there's a lot of wound leakage which is causes hypotonia, and there's small blood vessels, small capillaries start bleeding. So which plane which was blood free before you removed, that you can see so much blood, and it is basically like a second surgery to clear the blood itself. There is reduced post-op hypotony, which wound leak also is lesser. These high-speed cutters causes less retinal traction during the surgery, which is very, very important, because now I think we have cutters up to 20,000 cut rates. So the indications for diabetic vitrectomy are non-clearing VH, tractional RD, threatening macula, combined retinal detachment, progressive FVP after PRP, refractive DME with attached posterior hyaloid, macular traction, opacified posterior hyaloid phase, and eyes with rubeosis. So these are the new age machines. This is a constellation by Alcon. So more than the machine, I might have very good staff at my disposal. That is very important to my arsenal. We don't appreciate the scrub nurses enough. That is very, very important. Having a very good assisting staff is very important. Maybe the PGs, when they start operating full time, they'll understand. So a big shout out to all the nursing staff and everybody who assist us. So this is just a video showing a diabetic retinopathy case where the patient has a non-clearing vitreous hemorrhage with a nasal TRD. So we've cleared the vitreous hemorrhage. See, the advantage of all these small gauge machines and the high vacuum, high cut rate is you can go as close as to the retina. If you can see, we're almost touching the retina without causing any damage. So we've cleared the blood. This is a nasal TRD which we're trying to remove. So we're just trying to separate it from the retina. So we are using a scissors just to dissect the membrane. Yeah, the membrane is out. We'll just do some retinal laser and then just end of the case. That's it. Clear all the blood. All this is possible because of the small gauge vitrectomies, because you can work as close to the retina without causing much traction on the retina. So next, another video showing this in ILM peeling. This is done for a diabetic macular traction. So we just staining the ILM with something called a brilliant blue dye. and we just aspirating of all the excess dye.
Yeah, but almost we have to do some laser, make sure clean the material, all that. Let's pretty nice.
So this is called the pinch and peel technique, where you're just removing the ILM. Only thing is, word of caution to all the postgraduates: if you want to take up, if you want to become a VR surgeon, you need to have a lot of patience. It is not you do. It's not. It's unlike a cataract surgery. You do it today, the patient is so happy tomorrow. VR surgery, today you do surgery, patient's happy after a month, but he comes back to you after 6 months. Sir, onnum theriyala. He can always have a rebleed and the redetachment. Anything you need to have patience. If you're not patient, I think you can stick to your anterior segment. So we just removing the because a diabetic case, the ILM here is going to be little sticky. We're just trying to peel the internal limiting membrane, and we're just going to close the case. So we just removed the membrane and just fast forwarded. So we've removed almost everything here. How much to remove? From arcade to arcade, you can just remove it. That's all. Arcade to arcade is all these major blood vessels. Bear with me for 2 more minutes, almost done. So this was the surgery. So going on to next, what I have in my arsenal in the OT. So these are the wide field viewing systems. You have the biome bioculus, you have your Resight, which is there in our hospital here, which is Zeiss machine. You have Merlin by Volt, Apasami obviously makes, which is an Indian make. So these are the different viewing systems. Why this is important is, it took me at least 6 months to visualize what I'm doing. Half your retinal surgery is just to visualize what you're doing. If you can see what you're doing, half your surgery is done. It took me 6 to 8 months at least minimum during my fellowship to visualize, to see. So these are the new age microscopes which give you very in-depth, very bright, very good images with good contrast. This is the new Ingenuity viewing system. Basically here you have to wear 3D glasses, and there's a very high microscope which is just connected to your microscope. You don't have to look into the microscope. There is a basically 55-inch monitor which you can just directly look and you can do the surgeries. Here I used it only once, so I don't have much experience about this, but they say the depth perception, which is very essential for your macular surgeries and everything, is very essential. And these has a lot of filters on also in it, so you can make out the different tissues of your retina. I think, thank you for your patient listening. I think this take home message is, everything, like everybody said, everything starts at home. Avoid eating a lot of junk food, which madam already mentioned. Try eating food as much as possible at home. Regular exercise and regular screening will prevent any complications. Thank you so much.
Thank you so much, sir, for providing us with a clear view and showing us the path to this disease. It was a detailed and clear explanation about all the latest treatment options for diabetic retinopathy, which will be useful for PGs to update ourselves and improve our practical knowledge, also with interesting videos. Our final speaker of the session, due to special circumstances, sir has connected us through Zoom meeting. Dr. Kasinathan sir has done his DNB Ophthalmology National Board, FRCS Glasgow, many advanced fellowships in vitreoretinal surgery and many publications in renowned journals. We welcome you, sir, to enlighten us on the recent advances in surgical management in diabetic retinopathy.
Hello. Is my slide visible? Hello. Am I audible?
Yes, sir, you're audible.
Okay. At the outset, first let me apologize for not making it in person because I am just recovering from a viral illness. So So that's the reason, not any special circumstances, but I just couldn't make it because just recovering from a viral fever. So that's the reason. It's a great privilege and honor to come for a teaching classes, which I always love to do that. And it's an honor to share the dais with Namita ma'am, who is my teacher as well, and my colleagues Suresh and Rajesh. So diabetic vitrectomy, the tips and tricks, which I'm going to talk to you today. I think few of them have been covered by Rajesh. Slides are not moving. The slides are not moving. Okay. So the first ophthalmology or first corneal transplant surgeon is, I think we should always know some history, because when you teach for a postgraduate and teaching for a fellows is something different. Because history is very important, I would say, when it comes to the postgraduates. So the first eye transplant surgeon, as most of you know with the history, is Kannappa Nayanar, where there's a temple in Kalahasti. He's the first person to donate the eyes to Lord Shiva. And then the vitrectomy, we should never forget to look into our forefathers of vitrectomy. Robert McKeever in 1970 is the father of modern vitrectomy, what we call him. And he is the first person to talk about vitrectomy can cure retinal diseases. And this is the thing which is 20 gauge, which I would say the era was 10-15 years before. When we did a 20 gauge, we had suture granuloma, sutures, the eye was looking like that. On the right side, when you see the current 25 gauge and 27 gauge vitrectomy, the eye is as quiet as a cataract eye, as a phacoemulsification eye. So the eye is very quiet and the rehabilitation is also much faster in the current era. With the current technology, a lot of things have been improvised. One is the current cutters, which I will be talking briefly about the technology. The port size is much closer to the tip, thereby you can go work much closer to the retina. The cutting speed, when I started my fellowship, we used to use the cutter which is 750 cuts per minute. I don't know, Rajesh would have done with 2500. But when I started, it was 750 cuts per minute, but the current age is we have 10,000 cuts or even 20,000 bimanual cuts available. And then the port optimization. What is port optimization is the tip, the opening part of the cutter is very closer to the tip, so that you can work very closer to the retina. And the duty cycle, what they mean is the duty cycle is on and off. The on and off is almost we can manipulate with the machine. You can have it 70% on means that the port is open and 30% off means the port is closed. According to whichever plane you are doing or whatever stage of vitrectomy, you can modify the duty cycle at your will. And the trocar design. See, the current trocar design are spade type, which has cutting edges in the tip as well as in the edges, so that the cut is very precise. And then the instrument flexibility. See, more thinner the instrument, it's going to be more malleable and more ductile and more flexible. So that's going to be difficult with the vitrectomy, unlike the phacoemulsification, where you're going to sit in the head end or in the temporal side and then finish the entire case. Whereas in a vitrectomy, a lot of manipulation is needed. You need to do the base dissection, and vitrectomy, you need to have the base dissection, membranes, everything. So that the more thinner the instrument, is going to be more pliable. But with the current instrumentation, they have put an additional guard at the tip of the cutter so that it doesn't bend when you go to the periphery. And then the IOP control. The other advantage of the current vitrectomy technique is the IOP control. You can do, see, the best surgery in a vitrectomy surgery is to have a good IOP, because fluctuating IOPs, especially in diabetic vitrectomies, can cause rebleed, as Rajesh has mentioned. And with the current machines, we can control the intraocular pressures as well. And visualization techniques, the biome is a real boon. We started the vitrectomy, or I started the vitrectomy with the Lander's lens, where our assistant has to hold the lens. Here the assistant is more important than the surgeon himself, because he has to hold the lens firmly when you do the vitrectomy, which we call Lander's lenses. But now we have excellent biomes or the wide angle viewing system, which makes the life much easier. And then the elimination techniques. Elimination technique, what I mean, we have the Chandler elimination, we have bullet pipes, lot of variations. See, what I would say in my span of 20 years as a VR surgeon, I have seen a paradigm shift in the vitrectomy instrumentation, what I started with 750 to 20,000 cuts. And these are the cutters. This is Robert McKeever, what he used a 17 gauge cutter when he started his vitrectomy, which is around 1.42 millimeters, that is the size of the sclerostomy. Whereas moving on to 20, 23, which I started with a 20 gauge vitrectomy. And now we have a 27 gauge, which is only 0.4 millimeter. 0.4 is less than a 30 gauge needle. It's such a small, fine sclerostomies which used to make to do the vitrectomy. And you can see the cutting speed here, and that is the 1500 cuts. the video I'm trying to play. The mouse is not moving. Okay. Okay, in 1500 cuts, if you see, the cutter is working very close to the retina. The retina will be flapping in this video. I'm unable to play this video. I don't know why. And the retina will be flapping closer to the port. Whereas in a 10,000 cuts, you'll be cutting and shaving only the vitreous and working very close to the retina without much movement or traction on the retina. That's the advantage of increasing the cutting speed with an increased vacuum as well. So the vacuum doesn't pulse the retina, but increasing the cutting rate along with a good vacuum, you can work much closer to the retina. So that's the advantage of going with a 10,000 cuts. And then the other advantage, the reason improvement is the valve cannulas, because as we keep mentioning, maintaining the intraocular pressure is very important to maintain the hemostasis during diabetic vitrectomy. Now we have valve cannulas so that the intraocular pressure is always maintained at the desired level during the entire course of vitrectomy. And then for the diabetic vitrectomy, we have a good armamentarium of various types of forces like engrasping, ILM, asymmetrical, serrated, max rib, and recently we have another one called fish serrated forceps or sharpened forceps. And then this is a standard 20 gauge vitrectomy probe. You can see the port is much bigger, the opening is much bigger, the opening is away from the tip, whereas in a 23 gauge probe, which most of us use at the moment, you can see the port opening is much closer to the tip and the port size is also much smaller and the opening is also thinner. So this is again another video. How to play this? Okay. So this video you can see that the blue one is the traction retinal detachment and the green linear structure is the vitreous or the membranes. And you can see with the 20 gauge port, you are unable to get closer to the retina, whereas in the right side, which is the 23 gauge port, you can see the port is much closer to the membrane, you can work much closer to the retina. And then the other modification of the current cutters are the bevel cutters. It's not a flat, so no more, it's a bevel cutters in 27 and 25 gauge so that you can work much closer to the retina. And then this is from the Bausch & Lomb system, it is called Viterci or hypersonic vitrectomy, just like phacoemulsification. What this technology does is vit emulsification. They claim this is 1.7 million cuts per minute, but somehow this machine didn't have much of fanfare or didn't get much of approval across the globe. This is from the Bausch & Lomb. And then moving on to the wide angle viewing system, the panoramic view, all of us like to take such a good photograph with our current mobile cameras. And when I started vitrectomy, this is the lander system where one person has to hold the irrigating lander system, has to hold the irrigating lens on the cornea without moving his hands, and if in case he moves, that's why Rajesh was telling you need a good assistant or a good nurse when you do a vitrectomy, especially a diabetic vitrectomy, because the pressure point or the threshold for losing your temper is much easier when you do a diabetic vitrectomy, so you need to have a nurse who has a stable hands. And these are the lenses which are used. One is for the posterior pole, again for the periphery, and that is 30 degree and then 70 degree prisms were used, and we no longer use this system. And this biome is a current technology, and this is a wide angle viewing system. It's a beautiful system that has made the vitrectomy surgery very easy, and the time consumed for surgery is also much reduced, and you can work much closer to the retina. The depth perception is much better, the field of view is much better, and even you have a small pupil or a non-dilating pupil, which happens most of the time in a diabetic cases where the pupils don't dilate that much, you will be able to manage with a wide angle viewing system. And then moving to the 10 mantras for a good diabetic vitrectomy, moving on to the diabetic vitrectomy, the topic per se. It's always to have a good plan is like having a good roadmap. It shows the final destination and usually the best way to get there. So you always need to have a good game plan when you do a diabetic vitrectomy, because planning makes 50% of surgery easier. That's why during the fellowship we used to make a pre-op round, and we make a diagram the day prior to surgery. The fellow is supposed to go and see the patient on the bedside and make a good diagram, pre-operative diagram, and the consultant used to come for rounds and give us the tips about how to go about it, where to start the vitrectomy. So diabetic vitrectomy is just like not like a retinal detachment vitrectomy, where you go do the vitrectomy, see the hole, seal the hole, do a fluidic gas exchange, and then do retinopexy, and then put a tamponade. In a diabetic vitrectomy, a lot of planning is necessary, to which a lot of planning happens the day before the surgery rather than on the day. So the first one is step is the case selection. So what are the indications? When to operate? So these are the common indications for a diabetic vitrectomy. You can see a non-resolving vitreous hemorrhage. Then on the right side, you can see traction retinal detachment involving the macula. And then this is a traction retinal detachment threatening the macula. It's not directly involving, but it's threatening the macula. You can see some cystoid changes. You can see some ILM folds in the color fundus, which shows that there is a threatening on macula, and the OCT obviously will show macular threatening. And then a combined retinal detachment means there is a fractional component eventually leading to a retinal hole or a combined retinal detachment. And then there is another indication, then dense premacular hemorrhage, and then a diabetic papillopathy, which causes the traction, peripapillary traction, and on the traction on the macula as well. And then there is a dense asteroid hyalosis, which precluding the view to do a PRP. This is one of the indications because you know there is a PDR, some vitreous hemorrhage, but because of the dense asteroid, you are unable to see the fundus, then it's worthwhile doing a vitrectomy. But only problem when there is a dense asteroid is there is no PVD. Usually when there is a dense asteroid, there is no PVD. And PVD induction is one of the important steps when you do a diabetic vitrectomy. And then this is a premacular fibrosis or an epiretinal membrane or a vitreomacular traction, whatever you call it, a vitreous surface abnormality, which also can happen in a diabetic retinopathy. And then this is the vitreous interface abnormalities. In the OCT, you can see there is an ERM, and that's why OCT is a very important tool. See, when you see the color fundus picture alone, you will see, okay, there is a dull macula. There is some laser, previous laser scars, okay, it's a diabetic macular edema, we will do some laser or we do some injection. But once you do an OCT, when you see an epiretinal membrane or a traction, doing a laser or an injection is not going to do any good to this patient. So this patient is a clear indication for a surgical vitrectomy or a surgical diabetic macular edema. And the other indication being anterior hyaloid proliferation, and where there is a persistent NVE or NVI, and the patient is not responding well to the treatment and frequent rebleeds. So these are the indications for a vitrectomy. And again, other indications like a hemolytic glaucoma, which is very common, and then a complicated cataract, which can happen with a diabetic, long-standing diabetic traction detachment patient is ignored because of, and this is very common in these days because of the COVID scenario, 2 years or 3 years where the patient lost to follow-up. And you would have seen the patient 2-3 years before with a mild NPDR or a severe NPDR, and then 3 years later they come to you with a white cataract, maybe because of a long-standing traction retinal detachment or a combined RD leading to a complicated cataract. An ultrasound in this case is very important, know the status of the retina, and then based on the status of the retina and visual potential, surgery can be planned. And when not to operate, it's as important to know when not to operate in a diabetic retinopathy. A peripheral traction retinal detachment, which is not causing any traction on the macula, can be ignored. And macula threatening TRD with a very good vision, because if you say the vision is patient is having a 6.6 or 6.9 with the macular traction, and the patient is asymptomatic, better not to touch these patients. And a chronic macular retinal detachment with the ischemia, because the dull ischemic looking macula and vision is only 1/60 or 2/60, which couldn't explain the features of diabetic retinopathy, then it's a chronic ischemic macula. OCT will also help us to know the loss of the ISOS and photoreceptors. That also will help us to know that this patient may not be a good candidate for a vitrectomy. Because what only you should not worry about anatomical outcome, you should also think about the functional outcome when you do a diabetic vitrectomy. And a traction detachment, a peripheral, 20%, only 21% progress in the next 2 years. And the other recent onset vitreous hemorrhage with no macular traction. So that these are also not candidate for the vitrectomy. And whenever you see a vitreous hemorrhage in a diabetic retinopathy, you should not immediately jump into anti-VEGF injections, because anti-VEGF injections sometimes can convert a traction component to a combined retinal detachment. So you inject only when you see, the dictum is you want to give an anti-VEGF injection only when you see the features of the retina. If you don't see any features of the retina, please don't give anti-VEGF injection as the first line of management. And in this scenario, which side to operate well? Bilateral, you can see traction retinal detachment. Right side has 636 and left side has hand movements. In this scenario, I would always operate the left side, the bad eye first, even though the prognosis is poor. The flip side of this is, you operate the bad eye first, the patient will say, I didn't have much of improvement, I don't want to get operated on the good eye. So you have to weigh the pros and cons, depends upon the intellectuality of the patient. The patient needs to understand the right eye also needs to go surgery very sooner or later. Because doing a bad eye and then patient is not getting much improvement, that should not demotivate him as well. But what I would normally do, think in my way of thinking is do the bad eye first, at least he has the right eye to be ambulatory until we touch the right eye. And the left eye will have some improvement eventually. And then this is again another scenario. You can see the right eye had hand movements of vision, whereas left eye has only 2/60 because of vitreous hemorrhage. Again, you should not go only by the visual acuity alone. So in this case, you can see right eye, it's a tractional, it's a flat, there is no PVD, there is a tractional retinal detachment, there is no PVD, there is no laser cast. This right eye is going to be very difficult to operate because there is going to be a lot of adhesions. Whereas the left eye, you can see some laser cast, means they had previous lasers done elsewhere, and there is only vitreous hemorrhage. And vitreous hemorrhage in a diabetic retinopathy means there is a PVD, because PVD is the only thing which causes pull on the retina and causes a bleed. So when there is a bleed, it's a good sign there is some amount of posterior hyaloid separation has happened. So in this scenario, I would like to choose the right eye first. Again, in this scenario where you can see vitreous hemorrhage both the eyes, you can see disc easily in both the eyes, doesn't matter which eye you are going to operate first. And there is another saying, my teacher Dr. Mahesh Sharma used to say, in a diabetic retinopathy, more you see, more difficult the surgery is going to be. Means more features of retina you are going to see before the surgery, that's more difficult. Like you saw in the previous picture, we saw all the features of the retina with attraction. Here you don't see any features of the retina with vitreous hemorrhage. These are the eyes, the surgery is going to be easy. The prognosis depends on the macula, of course. But the surgical point of view, these eyes are going to be much easier to perform surgery than an eye where you see all the features of the retina. And then the second tip will be preoperative intravitreal anti-VEGF injections. This anti-VEGF injection, as Rajesh was mentioning, is real gold, but it should not be misused. It should not be used like a tricot. Tricot was sometime before the anti-VEGF era. The tricot or the triamcinolone acetonide was used right, left and center for any problem in the eye. So similarly, the anti-VEGF is being misused of late, but word of caution, because anti-VEGF can be a double-edged sword. So you can see a very angry looking prolapse like this, and you're going to do a vitrectomy. In this case, you're going to burn your fingers. So giving an preoperative anti-VEGF injection reduces the vascularity and also reduces the bleeding problems. And then it also going to induce some fibrosis component. So the problem is, that's why I was mentioning the red, when you're injecting in a vitreous hemorrhage without knowing what is the problem in the retina, sometimes a tractional component can lead to combined retinal detachment because of the increase in fibrosis. That's why when we give a anti-VEGF for a vitrectomy, it has to be spaced 3 to 5 days before surgery. And another word of caution is always get a physician fitness and ensure the patient is fit for surgery and then give anti-VEGF. Giving an anti-VEGF and checking the blood sugar, maybe 300 or 400, some nephropathy problem or this like something like that, and the delay in surgery sometimes may worsen the problem. So always get a physician fitness before you give an anti-VEGF and then proceed with the surgery after 3 to 5 days. That's the ideal time to do a surgery after anti-VEGF injection. And then the third tip, do I combine with the cataract surgery or not? Of course, if the VR surgeon himself is trained in cataract surgery, yes, he can do for the time-saving purposes, whereas in an institution, you have to call for an anterior segment person to do the cataract and then the VR surgeon does the vitrectomy. The other problem is, whenever the patient is above 60 years of age, what I normally do is when the patient is above 60 years of age, even there is some amount of nuclear sclerosis, it's worthwhile combining, otherwise it's going to be a two-step procedure, because if you're going to use a tamponade or the extensive membrane dissection, there is going to be worsening of the cataract. So when I normally don't combine cataract surgery is when there is not much of membrane is expected, it's just going to be vitreous hemorrhage, and ultrasound shows the PVD like this. It's going to be a simple vitrectomy. Yes, you don't need to combine with the cataract surgery unless cataract is there. And cataract is less than nuclear sclerosis grade 2, simple vitreous hemorrhage. And always it's good to do a preoperative biometry, because sometimes you don't know during the vitrectomy, sometimes you might change your mind, sometimes you might have a break. So we have surprises, and then you may end up in putting a tamponade. And then when you are going to go for a oil removal with a cataract surgery, doing a biometry in the oil filter is sometimes difficult. So sometimes it's good enough, it's wise enough for any vitrectomy which you are doing after 55, 60 years of age to do a preoperative biometry, so that choice of choosing the IOL power might be easy in a later stage. And when I combine with the cataract surgery, when I expect much more membrane peeling, and when I'm planning to use tamponades, and sometimes visualization could be hampered during surgery due to the cataract. You have an extensive membrane dissection, then having a lens in place sometimes might be difficult. So you knock off the lens, place a IOL, have a well pre-planned surgery, do a cataract, place an IOL, and then do a vitrectomy. Sometimes it's easier. And then, of course, as I said, if you're a VR surgeon who can also do the cataracts, then it's much easier. For a cataract surgeon, doing a phaco in a vitreous hemorrhage eye is a bit difficult because there is no red glow. Because most of them got used to work with a red glow, whereas when a VR surgery, when you're doing a cataract, there is no red glow. So you need to have much more expertise when to do a cataract in a vitrectomy surgery. And then the fourth step will be you have to establish a clear goal for surgery, because you should not give false hopes and expectations, because normally my diabetic consultations will say, or diabetic vitrectomy will say, expectation is the mother of disappointments. You have to be realistic. You have to give me the realistic goals, because diabetic is a disease which can be only controlled, cannot be cured. As you patient would have a very good vision after diabetic vitrectomy, say 612, 618, and 1 month later he might come again with a bleed. And the patient will say, no, after the surgery again the vision has gone down. So you have to have a good chair time with the patient when you counsel for a diabetic vitrectomy. You have to tell them sugar is a surgery, diabetes is a disease which can be only controlled, cannot be cured. And whatever the bleed is, now we can stop it, but future you can again develop bleeders if your sugar is not under control. So my first counseling will be good control of sugar is the first and foremost step, then comes all the other list of tests. And you can see, in any diabetic vitrectomy, what are we doing? We are doing only removing the media opacity, means the vitreous hemorrhage, then relieving the traction of the macula if there is anything, and then relieving the peripapillary traction. And the other tractional component is optional. You want, you can remove the other traction, otherwise you can leave it. And then obviously you don't want to create any breaks and put the tamponade. So these are the four basic things in a diabetic vitrectomy. So the best thing would be to remove all the media opacity, to remove all the macular traction, to relieve all the peripapillary traction, to remove all the tractional components in the retina, immaterial whether it is causing a visual loss or not. So that will be the ideal scenario, best scenario, and of course without creating a break, without putting a tamponade. But best is always not possible. So what we need to aim is a better outcome. A better outcome again, removing all the media opacities, removing the traction, at least the macular and peripapillary traction. The other traction is optional. And of course, while removing the traction, there might be some breaks, and if you have a break, then put a tamponade. That will be the better outcome. So all of us should aim at the middle level. And of course, you are a beginner, then the bottom one, the good one is better. But as I said, Rajesh was mentioning, diabetic vitrectomy is going to be the tough or the most toughest part of the vitrectomy. In a VR fellowship, or a person is wanted to become a VR surgeon, the diabetic vitrectomies are the vitrectomies which he has to touch at the last, after he fine-tuned his skills with the simple epiretinal membranes, and then retinal detachments, and then simple diabetic vitreous hemorrhages. And then the fifth tip, now moving on to the hardcore vitrectomy surgery, handling the hyaloid. So the first is debulking the vitreous. So vitreous is a nidus. Vitreous, as you know, vitreous is a nidus for infection, vitreous is a nidus for all the VEGF factors, and vitreous is a nidus which causes the traction on the retina and causes the bleeding. So first step in a diabetic vitrectomy is debulking the vitreous. So debulking the vitreous is just core vitrectomy, what we call. So you can see, you start from the center, go deeper and deeper. This is debulking the vitreous, first thing, because you need to have some space. Without doing a vitrectomy, you cannot directly go and pull the membranes on the retina. So first is debulking the vitreous, and second important step is disconnecting from the base. Disconnecting from the base means what we call truncation. So truncation of the cone. So that is disconnecting from the base. So that's called truncation. And then you can see a lot of attachments over there. And here you can see this video. So this is a vitrectomy. So this is debulking first, debulking the vitreous. Even though you can see the disc, you can see the membranes flapping, directly you don't go there. Once you have done debulking, then you go around the membrane, and then you can try trimming it all around. So this is truncation, means disconnecting the anterior posterior connections of the vitreous. So that is called truncation of the cone. And then start from the where do you start? Because in a diabetic, as I said, this is what the planning is important. So where do you start? In a diabetic vitrectomy, you cannot just start anywhere. So you start at the place of subhyaloid hemorrhage. The very reason there is a subhyaloid hemorrhage means there is a PVD separation there. So since there is a PVD separation, that's a good point to start your vitrectomy, initial vitrectomy. So start from the subhyaloid heme if present. That's why pre-op evaluation is much important. Sometimes if you don't see the fundus, it's a dense vitreous hemorrhage, and a preoperative ultrasound will show in which quadrant there is a subhyaloid hemorrhage or the vitreous separation. So that will also help us to decide about where to initiate the vitrectomy. And then assess for the movement of the hyaloid to make judgment about the underlying membranes, and look for vitreostasis, which is always present in a diabetic vitreous hemorrhage. Here in this video you can see. So this is a vertical scissors. Nowadays we don't use, this is a 20 gauge vitrectomy era. So you can see this, we're just dissecting around the membrane and then going towards the attachment or the peg finally. And then coming to so the first step in diabetic vitrectomy is the truncation of the cone, and the second surgical step is the membrane peeling. There are a lot of names have been given for the membrane peeling. So whichever, and it's not usually one technique alone. There are multiple techniques put together. Membrane peeling is done. And this is first one is called conformal delamination. Here the cutter is used on the surface, and then as the cutter is moved towards the membrane and the membrane is being aided. You can see cutter edge is applied over the rigid membrane, and rotate the cutter around the longitudinal axis to control the angle of attack and follow the retinal contour. That is very important. So you have to follow the retinal contour. You should know that eye is not a square or a rectangle, it's a ball, it's like a ball. So you have to go along the foveal retinal contour. You can see here, it just go towards them and keep on eating the membrane. This is the other technique, is called carpet rolling technique. Carpet rolling technique, here the cutter is placed on the surface of the membrane. The advantage of this is you are not directly touching the membrane or directly above the retina. You are above the membrane. So here the retina is well protected. This is the carpet rolling technique, where you roll the carpet, like you stand on the carpet and start rolling the carpets towards you. So that is what is carpet rolling technique. Here it can be done only when the membrane is freely mobile, and the advantage is the retina is well protected. And this is again the fold back cutter or the carpet rolling. It just the cutter, the membrane folds over the cutter and protects the retina. And this is the third technique, lift and cut, where the cutter is used as a multitasking instrument. Nowadays we don't use forceps, scissors or anything. The current age cutters are multitasking instruments. Here you lift the membrane and then cut it. Lift and cut, lift and cut. Lift is to find the cleavage plane, because you need to know how far away from the retina you are. So allow with the cutter, go into the vacuum mode, lift the membrane, and once you know the membrane is lifting, then you move on to the cutting mode and then cut it. So this is lift and cut. You can see the lift and cut. And the current day cutters, as I told, is a multitasking instrument. You can do everything with the cutter itself. And then another new technique is the proportional reflex. I'll show in one of the video, where if you don't find a plane between the membrane and the retina, you need a cleavage plane but you're not finding it, this cutter itself has a reflex. Like in a phaco you have a reflex mode. The cutter has a reflex mode. You just click the reflex mode, a fluid is gushed in between to create a cleavage plane between the membrane and the retina. So that will help in finding a cleavage plane to work on it. That's called proportional reflex. And this lawn mower technique is lawn mower, you know, when you use a lawn mower, you keep on eating and going forward and forward. This is nothing but the first technique, more or less similar to that. So you can see, you can go around all the, and wherever the attachments are there, you just leave it. You just go around wherever the membrane is mobile. That's why lift it, that when you lift the membrane, you know that the membrane is mobile, you can start eating it. And once you feel it is it's not mobile, means there is a peg of attachment of the nail to the retina. So those are the areas you have to be a little cautious and then go slowly, otherwise you will cause a retinal plaque or a bleed. And then in this video you can see. So this is the combined retinal detachment. You can see the ischemic retina. You can see this is a carpet rolling. You are over the membrane is folding to the cutter. And then now you are going, there is a vitreous crisis as well. And then you are going to the disc and then trying to lift the membranes. And this is what is the British technique. They do united, they stand together, they cause more problems. You just cut the membranes into small tiny pieces of islands. So you can see you are cutting into small tiny islands, and lift and cut and lift and cut. So lift and cut, this is a land mover technique. So you can just go underneath and then just make it into small islands. And with the current cutter, you see how closely we are working on the retina without causing any breaks to the retina. And then that's the macula. And then you can see the membranes are folding on itself, the lawn mower technique. Again, the advantage is these are bevel cutters also, so we are working very close. And these are the final attachment over the disc. You go with the forceps, just gently pull it over the disc. And with the cutter, if you are unable to find the cleavage, you can go for a proportional reflex, where some fluid will gush between the planes of the membrane and the retina. And then you can see nicely all the membranes have been removed. And these surgeries would have been a real nightmare during the 20 gauge era, or with the Landers lenses with the biome. These have become very easy, and the surgeons average VR surgeon's lifespan is definitely increased with the current technology and the viewing systems. You see how fragile and ischemic retina are these. These are the these are eye-saving procedures. And you can see the membranes coming up lively. That's one of the attachments pegs over there. Left hand cut and left hand cut. And you can see that's a break under the membrane. But the pre-existing break, not the active break. Active break means there will be bleeding, the recent onset. That's a pre-existing break. And these breaks are marked, and then you do a fluid air exchange and then put the oil or whatever to tamponade. And then coming to the disc fractions, the preoperative anti-VEGF is option because disc membranes are very vascular. So preoperative anti-VEGF sometimes may be very good to have in a disc membranes or papillary tractions. And you always have to deal with the disc membranes at the end. As you can see in the previous also, you finish all the peripheral membranes and then come to the disc membranes. Sometimes pulling the disc membranes can cause excessive bleed and it is very difficult to control the direct arterial bleed. That's why you have to leave it to the last. And the other thing is when you are going to remove the disc membrane, sometimes it's wise enough to increase the intraocular pressure. So that will act like a tamponade to prevent the disc bleed. And here you can see there is a disc membrane over there. There is a peripheral membrane. So directly we are not going and pulling on the disc. First we are trying to group the membrane over the disc. So pulling membrane all around the peripapillary area. And then just grouping it over the disc. Once you have done it, then you feel how much is the traction. Gently pull it and feel the traction. Once you know it's not much, increase the intraocular pressure to prevent the disc foods. Because sometimes you can see little failing of the disc, that's because the intraocular pressure is high. Sometimes if you don't increase the pressure, there will be disc bleed, excessive disc bleed that will prevent the further surgery. And then coming to the hemostasis, which is very important. Sometimes this is much more headache than the surgery itself. Membrane, you would have removed all the membranes, but achieving a hemostasis is a hilarious task, and that's where you need a lot of expertise and a lot of patience. So whenever you do a diabetic vitrectomy, the surgeon himself needs to have a lot of patience. And it's always, when you have a tough diabetic vitrectomy, always plan it in such a way that you are not stressed out on always have 1 or 2 surgeries in that day rather than piling up of more surgeries. So the ways of controlling bleeding, sometimes spontaneously bleeding can stop if you wait for a minute if it's a minor bleed, or you can increase the intraocular pressure, or you can do a fluid air exchange to control the intraocular bleed, and you can put a direct pressure by the cutter over the bleeder. And diathermy is very important. You have to use a diathermy to cauterize the bleed then and there itself. Don't allow the blood to pool. And preoperative anti-VEGF, when there is highly vascular membranes you are going to deal with, use preoperative anti-VEGF injections. And also don't forget to look into the monitor. Don't look into the patient eye alone. Look into the monitor also. Look for the hypertension. If the blood pressure is high, please inform your anesthetist to get the blood pressure under control. And then, as I said, do not permit large clots to form, because removing the clot itself will become much more difficult because they get stuck to the retina. So just remove the blood clots then and there and don't allow it to pile up. And sometimes removing the clot itself is of a diabetic for a VR fellowship training. And then control movements, moderately high magnification for membrane surgery, use a high magnification, wide angle viewing system is a real boon, and define the epicenter before cutting. So before you cut, you should know what you are cutting. Don't do a blind cut. Blind cut will cause a lot of bleedings and hemorrhages and breaks. So whatever you see, you do it. And in case you find it difficult, switch on to bimanual surgery. When there is a lot of extensive membranes, switch on. Don't hesitate to switch on to a bimanual surgery, where you put a chandelier over there and then use both the hands to do the surgery. And if the break occurs, don't panic. Take a deep breath, because creating a break in a fractional retinal detachment is going to be messy. It can convert itself into a combined retinal detachment. So it's going to be really messy, and don't panic. Take a deep breath and mark the break immediately with a cautery, because with the bleeding sometimes you may not see the breaks properly. and then resort to bimanual surgery if necessary, as I told, when there is a break, because pulling again membranes, the break is going to become, enlarged break is going to become bigger and bigger, and aim at a total release of traction, because whenever there is a break, then the surgery is going to be more and more meticulous, because you cannot really leave behind any traction. You have to relieve all the traction if there is a break has happened. And then retinectomy if need to be, because sometimes if the membranes are adherent, a tractional retinal detachment converts itself into a combined retinal detachment, pulling the membrane, causing again lot of breaks. Then sometimes you have to take a decision on the table how to complete the surgery, whether you want to leave it, come back later, or you want to do a relatively larger retinectomy along with the membranes and then settle the retina. And then the ninth surgical tip is to ensure a good visualization. Of course, without a visualization, the whole surgery is going to be difficult. So ensure a good dilation, use of iris hooks. If the pupils are not dilating, don't hesitate to use iris hooks or intracameral adrenaline. Scraping of the corneal epithelium, I know the corneal surgeons, the anterior segment surgeons don't like that, but to ensure a good visualization, don't hesitate to scrape the epithelium. And of course, cataract surgery, as I told, there is a lot of, there is extensive membranes need to be done. Then don't hesitate to do a cataract surgery in the same sitting as well. And wide-eye viewing system is really a boost. And you need to have a good visualization. And then surgical neckage to conclude. So now for a diabetic vitrectomy, being the port size is much smaller, 25 gauge cutter, they are beveled cutters, the port optimization, and then they are thin instruments, they can work underneath the membranes. So they are much preferred for a diabetic vitrectomy of late, and then they have high suction, even despite, you can use it with a high suction also, with the 10,000 cuts, even with the 500 vacuum, you can do a beautiful diabetic vitrectomy. And then if you are unable to find a plane, don't first always think, for a diabetic vitrectomy, you need to have a plane to dissect the membrane. If you are unable to find a plane, then it means there is a second membrane, what we call a second membrane. You need to find out the second membrane. That you can do by gently pulling on the disc. You can see some tractions, invisible tractions extending along the retina. Mean there is a second membrane. So unless you identify and remove the second membrane, you cannot remove the routine membranes. And then understand the anatomy of the membranes before you plan segmentation, because that's why a good preoperative planning is as important as the intraoperative decision making. And if you have an underlying sclerosis and adherent membrane, there is high risk of iatrogenic break, as you can see in the previous videos which I have showed you. And then the last but not the least, the most important tip is the realistic expectation. Always spend extra time, chair time with the diabetic vitrectomies, because these patients are going to be there with you. They are not going to leave you. They are going to be with you for a couple of years or decades with you. So tell them what I am doing now is to stop the bleeding. Whatever the current bleed is, I will stop it. But always diabetes, the disease which can be controlled, cannot be cured. You may have few bleeders in the future, and that might bleed and that may obscure the vision. So you can have another vision loss also. So tell them the first and foremost step is the diabetic control. So systemic control along with the other comorbidities like sugar, pressure, anemia, nephropathy, all the parameters has to be under good control. So what I meant by realization is a guarded visual success. You have to talk to the patient. It's not the anatomical success, it's a functional success also. And most of the diabetics don't promise them. See, in a diabetic vitrectomy, always don't give promises. I always tell my patients, the vision will be better than now. I don't tell them it's 50%, because number game is always deceiving. What is 50 for you may not be 50 for them. What is 80 for you may be 20 for them. So always don't play with the numbers. Tell them the vision will be better than right now. And then also explain them the chances of rebleed and the need for good compliance with the systemic parameters and good control of diabetic mellitus and other comorbidities, and also offer for LVA services if the vision is very poor because of macular ischemia. And most important thing which I keep on repeating is diabetes is a disease which is treatable and not curable. And then we should not forget it. So even though vitrectomy, everything in latest armamentarium is there, you have 20,000 cuts, you have 15,000 cuts, you have the better cutters, all the machines, technologies, we should never forget. With this ETDRS study, with a good PRP, only 20% required went for sight-threatening vision loss or vitrectomy. So 80% of the well-treated diabetics, means with the laser, still laser is a gold standard for a proliferative disease. 80% didn't progress to stage requiring surgery, so we should not forget our roots or the basics. Still laser is the gold standard. A good laser done for a proliferative disease will avoid surgery in at least 80% of the people. So that's why to summate what Dr. Namita Madam has said and what Dr. Suresh and Rajesh said, what is important in diabetic patient is not only just checking the eyes. You have to look the patient as a whole. You have to educate the patient because diabetic is a systemic disease. It affects head to foot every part of the body. So for a diabetic patient enters into your clinic, always spend a little bit extra time, explain them about the diabetic related complications, and also tell them diabetic is a disease which affects head to foot. It can cause microvascular problems, it can cause macrovascular problems, it can cause early death, it can cause early nephropathy, dialysis, all the things. Try to scare the patient with their diabetic related comorbidities. So that a good control of sugar is very important. And also you have to work in tandem with your physician because you need to have a good understanding with the physician. Because most of the patients, even though they live even in a metropolitan city, they don't know that diabetes can affect the eyes. So you need to work closely with your physicians, neighbors, friends, and tell them all the diabetic patients, according to the screening protocol, they need to have an annual eye checkup mandate. Because young diabetics are the more difficult ones. The young IDGM diabetics going to have the most tough diabetic vitrectomies. So good screening is important. And as I said, good counseling, good screening, proper treatment, timely intervention. These four are the key things for a good diabetic related outcomes for the patients. And the last one is the heads-up display of the 3D vitrectomy. I had an opportunity to do with this thing. And this is the latest newer thing for vitrectomy part of it, where because in a VR surgeon lifespan or the back span is much less compared to the anterior segment surgeon, because most of them gets a disc problems and neck problem because prolonged sitting hours. But with the newer technology, the sitting chair time is also getting reduced. Means the surgical chair time, increase your OPD chair timings, but decrease the surgical chair timings with the heads-up vitrectomy, where you can just look into the monitor and do with a good depth perception. And yes, this is a new armamentarium into our VR practices. And then this is again my concluding slide on diabetic. Any diabetic patient, I say 5 Ds are important. 4 Ds are important to control the 5th D diabetes. So first will be your diet, and then how much you eat doesn't matter, what you eat matters, and drugs means timely tablets and medicines, and discipline is walking, and then good doctor's checkup. So the 4 Ds are good control. The 5th D diabetes will not bother you. So that should be your concluding remark in any of your diabetic consultation. Thanks for the listening, and once again apologies for not making in person. Everyone wants to move in-person meeting, but unfortunately we have to carry on with the webinar because of my illness. Thank you again.
Thank you, sir, for the wonderful session and disengaging with the difficulties in understanding the retinal surgery in spite of your health conditions. You are joining us. Thank you very much, sir.
Thank you so much, sir, for taking so much effort, for making the special appearance in Zoom, and for keeping us on track of the recent advances and newer techniques for our CME.
Any questions from the audience? Any doubts I can clarify? Mr. Rajesh here. Hello?
Yeah.
Sir, I just had a doubt. One of your slides you said when not to operate. It is more essential than to know when to operate. But if it's a macular threatening TRD, say the patient has a rubeosis along with it, and good vision, 6/9, and it's a one-eyed patient, what would you do? So just do laser, or would you give an anti-VEGF and see how it responds? How would you go about that, sir?
No, if the patient is willing to be in a close follow-up, the compliance is very important. See, as you said, it's a one-eyed patient, okay? And patient is having rubeosis already. So means it's a progressive disease and has a macular threatening. So macular threatening vitrectomy is easy. You can do a good vitrectomy, relieve the macular traction. But rubeosis part of it, what you're going to do? So that's going to be the most important thing, and it's not going to be like one injection or laser is going to take care of the rubeosis. So what more bothersome is the neovascular glaucoma in future. So these patients, rather than keeping the hands put on the vitrectomy initially, first thing I will counsel the patient very clearly, tell him to have a realistic expectation. We are doing in a stepwise manner. First thing is I would do a good PRP. If the patient has not had a PRP well, I would do a good PRP, and then if there is with the PRP, if the rubeosis is decreasing, I would prefer to avoid the anti-VEGF in the beginning, because giving an anti-VEGF for rubeosis can sometimes increase the macular threatening more. The traction might be increased. So first thing I would do is first do a good PRP, because good PRP itself can reduce the rubeosis. And if the rubeosis is reduced and there is just a macular traction, it's going to be easy to tackle if it's going to be worsened. say the vision is 6.6 or 6.9, better not to touch it. So if the traction is going to worsen, then you can deal the macular traction. The most difficult thing is going to be the rubiosis or the neovascular glaucoma. So I would do it in a stepwise manner.
Thank you. Thank you, sir.
Hi Kasi, Namita here.
Oh, madam, sorry, man, Baramudile.
It's okay. I was looking forward to seeing you anyway. It was a wonderful talk. You started from the basics till the maximum which a surgeon can do. It was a wonderful videos also. Thank you so much. It must have been a real good class for postgraduates. Thank you so much. Postgraduates.
Yeah. History of vitrectomy, I had another presentation. I thought for cause of time we will do it later for them.
Okay.
Because history is very important.
Probably. Yes. Okay, nice meeting you. We'll meet in some other meeting.
Definitely, madam.
Bye. Have a great time.
Definitely.
Bye.
Thank you. Thanks a lot, madam. And thanks to the team from Melmaruthu Adigalar Medical College for calling me. I shouldn't forget to thank them as well. Only thing I couldn't be there in person, but definitely looking forward to be there and teach the postgraduates when time permits.
Next is enough. Check. துவக்க விழா நிகழ்வு. சபையில் நிறைந்துள்ள நல்லுள்ளங்கள் அனைவருக்கும் இனிய மதிய வணக்கங்கள். எங்களின் அழைப்பை ஏற்று இந்நிகழ்விற்கு வருகை தந்து சிறப்பிக்கும் மருத்துவ இயக்குனர் மருத்துவர் திரு ரமேஷ் அவர்களையும், என்றென்றும் எங்கள் துறைக்கு உறுதுணையாகவும் பக்கபலமாகவும் உள்ள மருத்துவ கண்காணிப்பாளர் மருத்துவர் திரு உமேஷ்ராஜ் அவர்களையும், கல்வி செல்வத்தை எங்களிடம் பகிர்ந்து அறியாமையுடைய அகற்ற வருகை புரிந்திருக்கும் சிறப்பு பேச்சாளர்கள் மருத்துவர் நமிதா புவனேஸ்வரி அவர்களையும், மருத்துவர் திரு சுரேஷ் அவர்களையும், மருத்துவர் திரு ராஜேஷ்குமார் அவர்களையும், மருத்துவர் திரு காசிநாதன் அவர்களையும், துறை தலைவர்களையும், பேராசிரியர்களையும், பல்துறை மருத்துவர்களையும், முதுநிலை மருத்துவ மாணவர்களையும், செவிலியர்களையும், மருத்துவ பணியாளர்களையும் கண் மருத்துவத்துறையின் சார்பாக இருகரம் கூப்பி வரவேற்பதில் பெருமகிழ்வு கொள்கின்றோம். தற்போது மூலமந்திரம் மற்றும் தமிழ்த்தாய் வாழ்த்து இசைக்க இருப்பதால் அனைவரும் இருக்கையில் இருந்து எழுந்து மரியாதை செலுத்துமாறு பணிவுடன் வேண்டுகிறோம்.
ஓம் சக்தியே பராசக்தியே, ஓம் சக்தியே ஆதிபராசக்தியே, ஓம் சக்தியே மறுவூர் அரசியே, ஓம் சக்தியே, ஓம் விநாயகா, ஓம் சக்தியே, ஓம் காமாட்சியே, ஓம் சக்தியே, ஓம் பங்காரு காமாட்சியே, ஓம் சக்தியே பங்காரு அடிகளே ஓம், ஓம் சக்தியே பங்காரு அடிகளே ஓம், ஓம் சக்தியே பங்காரு அடிகளே ஓம், ஓம் ஓம் ஓம்.
தமிழ்த்தாய் வாழ்த்து.
நீராறும் கடலுடுத்த நிலமடந்து கெழிலொழுகும், சீராறும் வதனமென திகழ்பரத கண்டமிதில், திக்கணமும் அதிர்ச்சிறந்த திராவிடனர் திருநாடும், தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே, அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற, எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே, தமிழனங்கே உன் சீரிழமை திரும்பி எழுந்த செயல் மறந்து வாழ்த்துதுமே, வாழ்த்துதுமே, வாழ்த்துதுமே.
சபையோருக்கு நன்றி. எந்த ஒரு மங்கள நிகழ்வையும் விளக்கேற்றி தொடங்குவது தமிழர் மரபு. அவ்வகையில் இச்சிறப்பான தொடர் மருத்துவ கல்வி நிகழ்வை விளக்கேற்றி சிறப்பித்து மேடையை அலங்கரிக்க வருமாறு மருத்துவ இயக்குனர் மருத்துவர் திரு ரமேஷ் அவர்களையும், மருத்துவ கண்காணிப்பாளர் மருத்துவர் திரு உமேஷ்ராஜ் அவர்களையும், கண் மருத்துவ துறை தலைவர் மருத்துவர் திரு வெங்கடேசன் அவர்களையும், நமது சிறப்பு விருந்தினர்கள் மருத்துவர் நமிதா புவனேஸ்வரி அவர்களையும், மருத்துவர் திரு சுரேஷ் அவர்களையும் மேடைக்கு அன்புடன் அழைக்கின்றோம். திரு ராஜேஷ்குமார் அவர்களையும் மருத்துவர் திரு வெங்கடேசன் அவர்களையும் மேடையை அலங்கரிக்க வருமாறு அன்புடன் அழைக்கின்றோம்.
Good afternoon, sir. A leader is the one who knows the way, goes the way and shows the way. With huge respect, we welcome our pride, Professor and Head of Department, Dr. M.J. Venkatesan, sir, to welcome the dignitaries. Please, sir.
Good afternoon, one and all. Before I begin to welcome everyone, I would like to seek the blessings of Arulmigu Adhiparasakthi and His Holiness Arul Thiru Amma for being so merciful with the blessings that led us the path we all traverse today. Om Shakti. Diabetic retinopathy is one of the important growing cause of preventable blindness, and it is imperative to treat it efficiently and effectively. I am sure the CME is answered in all dimensions. I welcome the bravest of the mind with heart of gold, Tirumadi Amma, for being the thrust of all heights we aim. For gracing this occasion, I also extend the heartiest and warmest thanks to our Managing Trustee, Shakti Kopa Tripan Baragan, for being ever so kind in extending his ideas and support. My deepest gratitude and sincere thanks to one and only, very approachable, friendly, ablest administrator of all, our beloved Medical Director, Shakti Ramesh, always been a source of great inspiration and energy that propels us to the higher standards. It gives me immense pleasure in welcoming you, sir. Also to the very kind and helpful Professor Mohan Singh, Vice Principal Kannan, Deputy Medical Student Professor Umesh Raj, HODs and faculties of other departments, staff one and all. I extend my welcome and thank you all. I welcome with profound gratitude all the eminent speakers who have agreed to grace this occasion and share their rich experience in spite of their busy schedule. Dr. Namita Bhuvaneshwari Madam, HOD Meenakshi Medical College, former Director of Regional Institute, a hallmark of great teacher and a versatile ophthalmologist. Dr. Suresh Sir, HOD Railway Hospital, the most devoted teacher and a multifaceted surgeon. The aura that he emanates is super amazing. Dr. Kasinathan Sir, a leading experienced vitreoretinal surgeon in the city and excellent academician. Though he is not physically present here, he joined us online. Dr. Rajesh, my dear friend, a passionate and dedicated vitreoretinal surgeon, I stand transfixed at the momentum of the growth this gentleman has shown over these years. Thank you for staying with us through thick and thin, Rajesh. Welcome all the postgraduates, delegates from our institution, every other institution, undergraduates. Let's make it great. This is our event. Let's cherish it. Thank you all.
Thank you, sir. The more humble and transparent a leader is, more effective his workers are. We are immensely proud to welcome our humble leader, our inspiration, Medical Director Dr. T. Ramesh sir, to inspire us more by sharing his words on our CME.
ஓம் சக்தி, குருவடி சரணம், திருவடி சரணம். முதலில் எங்களுடைய ஆன்மீக குரு அருள் திரு அடிகளார் அவர்களின் பாதம் பணிந்து நம்மை வழிநடத்தி கொண்டிருக்கும் திருமதி அம்மா அவர்களுக்கு என்னுடைய வணக்கத்தை கூறி இந்த உரையை ஆரம்பிக்கின்றேன். So today we are all gathered here for CME on Diabetic Retinopathy organized by Ophthalmology Department of our hospital. First I would like to congratulate Dr. Venkatesan. So Dr. Venkatesan is very simple and is very close to me also. In this present era where doctors are getting bad name for their arrogance and non-approachability, Dr. Venkatesan is setting a different example where he is very simple, yet at the same time he is talented, very hard-working. When you look at him, you will get misguided by his appearances, but his work speaks for a lot for his abilities. So with his captainship, ophthalmology department is doing great heights. You all know ophthalmology is very special for our Adhiparasakthi hospital. Every year on March 3rd we used to celebrate our founder's birthday. So nearly I think We are doing more than 1,200 cataract surgeries per year, but for the past 3 years we didn't do because of COVID situation. And in this coming year also we are going to conduct a similar camp in March last week. So with this Dr. Venkateshan's leadership, definitely we are going to achieve another good number of cases we are going to operate. And at this juncture, I fondly remember Dr. Namita madam, because she used to collaborate with us for a very long time. I think for past 5-6 years she didn't come here, but she is very, from the beginning years when we started the eye camp on our own in the year 2005, I think. Madam used to come regularly. So I started feeling very nostalgic, madam. At this day, I welcome you to our hospital, and after it's very pleasure seeing you after a long time. And at this stage also, I fondly remember Dr. Madhivanan and Dr. Chalini Madhivanan also, because with their guidance only we started that eye camp, and any eye camp I used to remember them with so much gratitude. I wish all my prayers to them also. And I welcome Dr. Suresh, Dr. Rajesh, Dr. Venkateshan Chellappa, and other DMS, other HODs, and all postgraduates and delegates. So நான் வந்து ஒரு சிம்பிள், எனக்கு வந்து இப்போ டாக்டர் வெங்கடேசன் பற்றி பேசும்போது I remembered one book. So I think all the budding ophthalmologists or all the doctors should read that book. There is a book called The Infinite Vision. படிச்சிருக்கீங்களா? Ophthalmologists, PGs. Definitely you should read. There is a book called Infinite Vision. It is about the founder of Aravind Hospital, Dr. Venkateswamy. So Dr. Venkateswamy is fondly called as Dr. V. I think GV, but everywhere it has been quoted as Dr. V. Because why I fondly remember our HOD also by Dr. V. So we are also having Dr. V in our side. So you should all read that book. So when Dr. V visited one of Dr. G surgeons, maximum number of patients can be operated. So that the same principle only I think we are also following, and they introduced something called freemium treatment. You all should read that book, and every doctor I think they should read this book. So I don't want to keep on extend my speech because already it is 1:30. We're all very hungry and the nice food is also waiting. And once again I congratulate ophthalmology team for conducting such a nice event and inviting me. And our hospital management is welcome in conducting such events. We expect more number of people to attend, gather more knowledge. Thank you, sir. Thank you for inviting. I wish all the program organizers my best wishes to all the program organizers for conducting such a nice event. Thank you. Thank you very much.
Thank you so much for your wise words, sir. I now request our HOD, sir, to felicitate our MD, Dr. Ramesh, sir. Meena. Successful teams don't happen by accidents. They are made through constant effort and determination. We proudly welcome our medical superintendent, Dr. Umesh sir, who encourages us on teamwork, to share his words on CME.
Good afternoon and all. I just Adhiparasakthi. With the divine blessings of His Holiness Auditorium Amma, ever-loving guidance of Tirumadi Amma, and the star leadership of our Honorable Medical Director Dr. Ramesh sir, I wish this CME conducted by the Ophthalmology Department a grand success. Success is a good thing, I agree, but success with silence is a great thing, right? The testimony for that is the highest number of eye surgeries in surrounding 3 districts is by the Department of Ophthalmology. I like to have a big round of applause for that. In the whole 3 districts, the highest number of surgeries is done by this department. That's called success with silence, right? This conference on diabetic retinopathy is a well-chosen topic because India is often referred to as a bad reputation as a diabetes capital of the world, with about 17% of the world population, and Tamil Nadu is one of the highest prevalence disease. So this topic is definitely a burning issue. So 1 in 2 Indian diabetics doesn't know that they have the disease. So we have to improve the screening measures. And for this topic, diabetic eye disease is a very preventable cause of blindness. And so I thank all the speakers who have come a long way to share their rich hands-on experience of their treating in diabetic retinopathy. Thank you all. Thank you. I wish this program a great success. Thank you.
Thank you, sir. I now request Professor C. Venkatesan, sir, to felicitate our MS, sir. There is no greater joy than respecting and honoring the wonderful aspects of personality who has come all the way to our CME. I now request our beloved Medical Director Dr. Ramesh sir to felicitate Dr. Namita Bhuvaneshwari ma'am and honor with fruit basket. Thank you, sir. We now request our MD sir to felicitate and honor Dr. Suresh sir with memento and fruit basket. We now request our MS sir. We now request our MS sir to felicitate Dr. Rajesh sir. Thank you, sir. I now welcome our Professor Dr. C. Venkatesan sir, Department of Ophthalmology, to deliver his vote of thanks.
Good afternoon all. On behalf of Department of Ophthalmology, I would like to extend my heartfelt gratitude to our Vice President, Adhiparasakthi Charitable Medical Education and Cultural Trust, Shakti Tirumadi Amma, Lakshmi Bangar Adigalar, and our Managing Trustee, Shakti Thiru Anbalagan sir, and our Medical Director, who had always been in support of the hospital and our department, Shakti Thiru, Dr. T. Ramesh sir, for his support and guidance throughout this CME, and our Dean, Dr. Mohan Singh sir, for his kind support, our MS, Dr. Umesh Raj sir, for his constant encouragement and support, to all the speakers who has enlightened us through their knowledge. Regarding the speakers, this is an interesting mix. Madam was my professor, she was my teacher, and then I also had worked under her as assistant professor. Dr. Suresh, he was my colleague in my PG days. Dr. Rajesh, he was my student, he was my MS student. And Dr. Kasi sir, he was again my colleague who I was working, benefited with that. And I also thanked all the participants of our CME program from the various other departments. I would extend my gratitude to all the staffs and faculty members of our department who made this event possible. And above all, my sincere thanks to our technical support team and the maintenance team. Thank you all for helping to make this CME a successful one. Thank you very much.
Thank you, sir. Now we will break for lunch for 1 hour. After lunch, we have an exciting PG quiz. I request all postgraduates after a biryani fest to participate in the PG quiz and win exciting prizes.